Doctor, we are live now.
Thank you. So a warm welcome to everybody all around the globe who are part of attending this Naadi Season 3 by the Young Ophthalmologist Society of India. And this is an international online case competition for this year, and this is the last day of the preliminary case competition supported by Neomedics. And in Tirukural, there is this line, a very famous one, which denotes diagnose the illness, trace its cause, seek the proper remedy, and apply it with skill. So, Noi Nadi, Noi Mudal Nadi is how it starts, and this is one of the lines that was conceptualized and inspired by Dr. Karthikeyan Mahalingam. And it was he who brought a team of three people for the first edition that you can see in season one, where we started in a very small way. We had a humble beginning with around 25 participation, 25 to 25 plus participation under the leadership of Dr. Sonal Kalia ma'am. And we were well supported by Dr. Nirmal Frederick sir for the awards and the motivation. We had a prelims and the judges with most of the judges are still part of our judging panel. We are very grateful to them, especially Dr. Deep Shekhar Das, Dr. Gunjan Saluja. You can see that they were all part of the judging team of the past as well, and Dr. Ashwini Kumar Behra, to name a few. And again, for season two last year, once the new team took over, we were lucky to have Dr. Devakant Mishra sir, another dynamic president, to continue this for a season two, where we wanted to expand it with not two preliminary rounds, but we were expand to three preliminary rounds with anterior segment, vitreoretina, and miscellaneous, but it was still open to the Indian contingent. And for the finale, we had the Glaucoma Society of India President Dr. Satyan sir and few senior ophthalmologists judge and help us decide the winners who are crowned at YOSICon International 2025. So on that note, with the vision of this dynamic team and again Dr. Devakant Mishra sir, who has shown us the way for international waters, this team really wanted to see if we can really go international, and that is what season 3 goes international was our tagline. And we had close to 95 submissions, an unprecedented 95 submissions from what we had last year to around 35 plus submissions. Thanks to this dynamic team and the office bearers and the executive members and the PWG members who all helped us in getting their residents on board to make this possible, along with our international YO leaders. So with that, we would like to welcome our judges for today, who has taken a lot of time for the next few minutes and hours. Dr. Arshi Singh, again, fondly call her my glaucoma sister, and who's an assistant professor and a very dynamic glaucomatologist practicing in New Delhi and a gold medalist. Welcome, Dr. Arshi, for today. And we have, thank you, Arshi. We have Dr. Akshaya Balaji, again, another very dynamic and a promising ophthalmologist who has also been part of our previous ventures from post-graduated from RP Center, and many accolades and publications, to name a few, in DOS, IGO, etc. Welcome, Dr. Akshaya. And thank you. We have Dr. Mohammed Ibrahim Asif. Again, Dr. Mohammed Ibrahim Asif has been a strong pillar for Noinadi from season one, which started 3 years back in the month of March 2023. And again, sir has also completed from the RP Center, and he's now a full-time, he worked as a full-time consultant at I7, has published 75 articles and has presented in various conferences. Thank you, sir, and many accolades to his credit. And we have our international panel today, Dr. Lala, who will be joining with us shortly, along with our very own Dr. Vinod Arunachalam, sir, who has also been a great pillar for YOSI. He's a medical director of Vinod Eye Care, and he has founded the Trichy Glaucoma Foundation, a first generation ophthalmologist who has built his empire from scratch. And thank you, sir. Many accolades, 7,000 cataract surgeries, top 3 ophthalmologists in Trichy, to name a few. Thank you for joining us today. And we have.
Thank you, Prasanna.
Thank you, sir. And I'd like to hand it over to Dr. Pranesh to introduce the next few people and then give it to the moderators.
Next person, I would like to introduce Dr. Lipi Mittal, who's a consultant cataract and refractive surgeon at CFS Palwal, executive member of YOSI, a very dynamic person. She's a editorial member of your newsletter and team member of YOSI IROC. She's the winner of annual YOS Lights, runner-up of YOSI Journal Club, and she has many other accolades. She has won in Roscon, Yo Cards, and she's delivered various presentations, and she has also presented an AOS ARC webinar on how to excel in her residency. And next moderator, we have the ever great Dr. Niranjan, a backbone of Naadi. So, best outgoing student of RIO and really hard worker and the very important for the functioning of the Naadi event. So, for the next, we have Dr. Ayutreya Varman, again an excellent cataract and refractive surgeon. So, he has performed more than 3,000 cataracts and 2,000 smiles. Chief instructor in ASCRS, and he's presented many live surgeries and national international conferences. We have next Dr. Rolika Bansal. Who's done specializing in oncology and oculoplasty from Mahatma Medical College and Hospital at Jaipur, Rajasthan. She has more than 100 research publications and 80 publications, 100 research products, won more than 75 awards. So it'll take a whole hour to read all the awards. So that's it for the both the panel and the judges. Thank you, Dr. Prasanna.
With that, let us kickstart the last day of the Naadi Season 3. Before we start, we have the valedictory ceremony at 7:30 today, where we'll be announcing the results of all the 3 preliminary sessions, and let's see who and all get selected for the physical YOSICON international presentation. And with that, I would like to hand over the session to the moderator, Dr. Niranjan, to start the proceedings.
Thank you, sir. Thank you so much. Warm welcome and a very good evening to all the participants and the judges and the panelists who've joined us for day 3 of this marathon case presentation, Naadi 3.0. So without further ado, let's start. I call forward Dr. Mohammad Somir Hossain, all the way from Bangladesh, to present his case on Vogt-Koyanagi-Harada syndrome. Over to you, Dr. Hossain. Kindly start your screen sharing. Manjula ma'am, can we have the timer link in the chat box, please?
Sure, doctor.
Should I start?
Just a second. Yes, doctor, please, all yours. Please go ahead, Dr. Hossain.
Sir, I think you can just pass the timer. Then there's some glitch, I think.
Okay, I think he's having a connectivity issue.
Dr. Sumir, are you available? Are you with us?
The next person is also ready, just in case if you want to take the next person.
Okay, I think he's lost his connection. So, but he's still screen sharing. So, I think.
No, ma'am, can we stop the screen share and go for the third person first?
Okay, doctor. 1 second, doctor.
And meanwhile, all participants kindly stick to 4 minutes time for presentation. Overshooting will attract negative marks. So better to stick and be crisp. Keep it short and sweet.
I think the participants got the cues, Karthikeyan sir. Thank you for the tip upfront. Okay, next up we have Dr. Titsia Hun from Cambodia, presenting a case on complexity in the management of microsporidial keratitis. Over to you, Dr. Hun. Yes, we can see your screen. Please go full screen.
Okay, sir. So
Yes, please
can
start.
start right now. Okay. Hello, everyone. My name is Tet Hun. I'm from Cambodia, currently a cornea fellow at Tiranda. Today, I'm going to present about microsporidial keratoconjunctivitis. I have no financial interest. So between these two patients, they're so similar, and we can see there's some STK. But the thing is that this patient respond very well to FML, but this patient doesn't respond very well because this is the case of microsporidial keratoconjunctivitis. To jump into our case report, this is a 19 years old male patient. He had keratoplasty done 3 months back because of the viral scar, but he came with sudden redness. And on examination, we can see contentable hyperemia and this whitish lesion here, but it is not so specific, so we just give him antibiotic and send him home. But 3 days later, he came back with this increased in lesion. There like to be something that stuck on his cornea, and we do some smear, and then we can see the presence of microsporidial spore. So we decide to do the debridement for this patient, and we also give him moxifloxacin, voriconazole 3 hourly, also the oral albendazole, and of course we stop the prednisolone acetate. And in just 2 days, he came back without any recurrent other lesion, and we can see just epithelial hearing line because of the debridement. And so we start his prednisolone acetate, and after 2 weeks, he came back with clear cornea. So for the discussion is that the microsporidial keratoconjunctivitis is not that uncommon, but it is very confusing with the viral infection. It is said to be cell-limiting, but the outbreak is mostly during the rainy season in regions such as South Asian and also Southeast Asian. Like in the study in the South Indian, you can see there increased incidence of the infection, not because there are more people that get infected, but it's because the ophthalmologists they become more aware of the infection, and so as a result, we can see an increase in case. So there's two types of infection, which is the superficial one and also the stromal infection. The stromal is associated more of poor prognosis, and the species is vitelliform cornea. But in the recent report, there's increase in the incidence of PC confirmed of vitelliform cornea, especially in the keratoconjunctivitis form. But the problem in the management is that there's no standard management. So everything is based on experience. And the most important thing is that we have to justify our management. So regarding the cornea debridement, there are a lot of conflicting in the report because some case they said it is not beneficial, it is a cell-limiting disease, but for some other, including myself, I believe that cornea debridement by removing all of this lesion would help the healing faster. Regarding the medical treatment, there are a lot of regimen ranging from chlorhexidine to magilin, also the combination of fluoroquinolone and voriconazole, and even the additional of albendazole as well. But the thing is that all of this report, they said their regimen is the success. So as a reader, we cannot know which one to follow. But the most famous one would be the fluoroquinolone and voriconazole combo because it is more available, not because it is more effective than the other, but it's available in most countries. So regarding our case, we are being aggressive with you a lot of medicine because there are a lot of report of the vitelliform cornea in the keratoconjunctivitis form, and this is a case of post-keratoplasty, and it has this worsening of initial presentation. So we want to be more aggressive in the management in order to get the optimal eradication. For the take-home message, microsporidial keratoconjunctivitis is not uncommon, but it is very confusing with the viral infection. So because there are no standard protocol, we have to balance between the over-treatment and treatment, but we choose to be more aggressive because there are a lot of dyspepsia, and we have to consider the use of steroid because when there's no more of the lesion, then we can start steroid to minimize the complications such as the haze and also the physical reaction. So this is the end of my presentation. Thank you, sir.
Thank you so much, Dr. Hoon. It was a wonderful presentation. Now, I think we'll call forward, uh, yes, Dr. Lippi
Yeah,
to share
hi.
her perspectives on this case, please.
Hi, Dr. Titsa. It was a very well presented case. Since you know the treatment differs entirely, how would you differentiate between a microsporidial keratitis and an adenoviral keratitis?
Yes, ma'am. That is the most problem that we face because it's still very difficult to define to differentiate between the two. But we see some trend in the microsporial form is that there is some step on lesion. It's not like the normal SPK that we see in the keratoconjunctivitis. There's some lesion that seem to be like a foreign body that step on the cornea, and we can find this ring lesion that look like a shooting target ring lesion. So whenever we see this all of this sign, we are trying to ask the patient to get some smear to confirm if it is microsporidial or not.
Yes, I think it was correctly mentioned. Microsporidial has stuck-on lesions whereas adenoviral have more fine SPKs or subepithelial infiltrates also. Also, sometimes it is about the laterality also. In microsporidial, it is mostly unilateral, while in adenoviral, it is usually bilateral, not always. And of course, you have rightly mentioned the treatment. It differs. In adenoviral, we advise and prescribe lubricants and steroids, while steroids are not indicated in microsporidial keratitis. So I think it was a good presentation. Thank you.
Thank you. Thank you, Dr. Lippi, for your valuable insights. Can I request Dr. Hoon to stop screen sharing? Yeah, thank you. Thank you so much. We shall move on to the next presenter. Um, I request Dr. George Rel Matias from Egypt. Are you there with us? Okay, I think
Dr.
Yes,
Sumir
Dr.
is ready.
Somir is here. Okay. Dr. Somir, are you ready with your presentation? Shall we go ahead?
yes, we can.
Perfect,
May I
perfect.
share?
So, yes, please. Yes, please. Yes, Dr. Somir, please start.
Okay, thank you. Hi, I'm Dr. Shumit from Bangladesh, presenting a case about Vogt-Koyanagi-Harder syndrome. A 15 years girl, she's a student. She came with the chief complaint of pain, redness, photophobia, lacrimation, and gradual dimness of vision in both eyes for 1 year with multiple floaters for 6 months. When I asked her, her eye ache was mild to moderate in nature. Due to photophobia and lacrimation, she had to skip classes. She went to an optometrist, but the spectacle didn't improve the vision, neither the symptoms. Few days later, her symptoms improved, but after 2 months, similar symptoms, that is, those pain, redness, photophobia, they came back, persist for 1 to 2 weeks, and then vanishes. Gradually, her vision starts to deteriorate, and after 6 months, she was seeing floaters. There were repeated episodes, like after 3 months, the duration was for 10 days, then after 2.5 months, the duration was for 15 days. With each attack, her vision was deteriorating. Then her parents consulted an UVA specialist. On systemic history, she had a dengue fever prior to all the symptoms described. There was no history of TB, diabetes, renal failure, or joint pain. No history of any kind of ocular trauma or surgery, ingestion of unpasteurized milk, undercooked meat, contact with pets like cat or dog. No history of arthritis, back pain, gastric ulcer. Patient is not sexually active. No history of syphilis or HIV. But patient has vitiligo. Other systemic features like hearing difficulty was absent. Neurological examination also reveals no signs of neuropathy like hemiparesis or aphasia. Well, on slit lamp, her vision was 5 by 16 and 2 by 16. Color vision seems trichromatic. Contrast also seems normal. Extraocular motility was full in all gaze and it was painless. Conjunctiva, congestion, bilateral congestion, cornea shows granulomatous P, cells are 3 plus and 1 plus. Pupil was 360-degree posterior synechia. IOP was 52 and 34. She has bilateral cataract and there is no fundal view. Patient is very religious. She didn't allow me to take any pictures. So my provisional diagnosis was BK syndrome. I thought about the differential, but there is no history of trauma, so not sympathetic ophthalmitis, no history of oral or genital ulcer, any causes that causes posterior uveitis, any infectious causes, no history of syphilis or tuberculosis. So I did a B scan on both eye, and I did other investigation like CBC with ESR, SGPT, surface antigen for hepatitis B, random blood sugar, and serum creatinine because I'm going to start the methotrexate. Well, on the July, the WBC count was 10,000, but after starting the steroid and the methotrexate on 9th October, I do another CBC and it is 7,300. And neutrophil count was 86%, it becomes 59%. Rest of the serum creatine, RPS, SGPT, they are normal. The B scan shows choroidal thickening. So we started prednisolone orally in tapering doses with omeprazole and calcium supplement, methotrexate, acetazolamide and potassium supplement, brimonidine, and prednisolone eye drop. Now, long-term prognosis of VKH, Professor Ecoriniti did a research over 30 patients, follow-up up to 120 months. He preferred IV methylprednisolone, but Professor Reed et al. He said, route of administration of the corticosteroid did not affect the final outcome. So next plan is when the inflammation is settled, we will do cataract surgery in both eye and vision rehabilitation. Thank you very much.
Thank you, Dr. Sumit. I think you were bang on target with the timing. So now I request Dr. Lala from Azerbaijan to share her perspectives on this case, please.
I think Dr. Lala is joining a bit late. Is she?
Okay.
I think she's there. She's there, but I'm not. She's there.
Okay.
We'll take up retina. We'll take up retina cases for Dr. Lala.
No.
Okay.
Yeah.
And Dr. Lala asked for this.
Okay. Dr. Lala, are you there?
Yes. Okay. Or we'll call upon Dr. Akshaya for discussion. Dr. Akshaya. Yeah, here.
Nice presentation, Mr. Somir. Pictures would have added more information actually in this case, especially to see, since I have not seen this case. So how do you think, any other differentials that came to your mind while seeing this case? And how did the systemic investigations add value to your diagnosis?
Dr. Samir, are you, maybe there's internet connectivity error, his screen is still. Okay. Maybe we'll take on the questions later. Here, Dr. Samir can answer in the comment box. We can move on to next presenter.
Okay, sir.
Yeah.
Thank you. Now I invite Dr. George Adel Matthias from Egypt with a very apt title, The Pharaoh's Lost Treasure, A Ring in the Ruined Tomb. Over to you, Dr. George.
Hello, how are you? I will share the screen now.
Yes, sir. Yes, please go ahead.
Okay, can I start? Okay, good morning. This is George Adel Mansour, a lecturer of ophthalmology in Shams University. My topic today about the Pharaoh's lost treasure, a ring in a ruined tomb. My case was 65 years old male, came complaining of poor vision on his right eye of 10 years duration. He gave history of blunt trauma to the right eye 10 years ago. Since then, he has poor vision, and he was told that there is nothing to be done for his case. By examination, vision was hand motion with good projection. Anterior segment showed myotic pupil with dense pupillar membrane with apparent mature cataract, hardly seen with posterior synechia, no view of the retina. The other eye was unremarkable except for nuclear cataract grade 2. Further investigations were done showing flat retina by B-scan and mild conduction abnormalities by VEP and ERG. My decision was to do cataract extraction after releasing any adhesions and synechia. And this is our video. First, we did 2 side ports, an injection of trypan blue stain. then injection of OVD, trying to release the posterior synechia with a Sensky hook and with a micro scissors, then trying to dilate this narrow aortic pupil using iris hooks for better evaluation of the case and for better assessment, and then injection our OVD. Oops, we don't have cataract. We have absorbed lens, opened anterior capsule with a sombring ring. So my decision was changed to fashion this cut anterior capsule into a rhexis and to try to remove this sombring ring and to implant intraocular lens. I tried with IA and then I tried with a vitrectomy cutter to release this adherent sombring ring, which was very adherent to the posterior capsule, despite using OVD to release it. Then I tried to use a Sensky hook to release it from the posterior capsule, and as you see, the bag was moving. So my decision here was to implant capsule tension ring for two reasons. The first one is to stabilize the bag, and the second one is to make a dissection plane between the posterior capsule and this sombring ring, which may facilitate its removal. So as expected, this makes the sombring ring more easy to be dissected from the bag, and then using a phacoemulsification machine to emulsify this very hard and very dense 10 years duration sombring ring. After removing the sombring ring, I used IA to remove the remaining cortex cautiously to avoid any tear in the posterior capsule, which is our last hope. Then we injected OVD to fill the anterior capsule, and my decision is to implant 3-piece IL in ciliary sinus. Then removal of the iris hooks, an IA of the viscoelastic material, then stromal hydration of the wounds. As you can see, the iris was coming out, so my decision to close the wound using nylon 10-0 stitches in a finger of 8 fashion. Our postoperative was the patient gained best corrected vision acuity of 0.6 instead of hand motion with clear cornea and well-centered IL after 1 week of the operation. My take-home message: in long-standing poor vision, electrophysiology can be of preoperative prognostic value. UBM is a good investigation to rely on in assessing such cases. Be prepared for any scenario with your instruments and ILs, and please be calm dealing with any surprises. Never to lose hope in helping people to regain their vision. At end, you are invited to discover our ancient treasures at our new Grand Egyptian Museum, where you can find thousands of Egyptian treasures. Thank you so much.
Thank you, Dr. George, for the entirely nice theme of Egypt and the invitation to all our YOS to the museum as well. Now I invite Dr. Mohammad Ibrahim Asif to share his perspectives on this case, please.
Hi, Dr. George. It was a nice case, and it was very well managed. And preoperatively, were you able to make out with the ultrasound if there is the lens was normal, or it was like partially absorbed or something? Were you able to make out? Or of course, UBM would have been a better option. So
I did.
Yeah.
Sorry. Okay. I did the ultrasound B scan already. It was fun. It was fun that there is cataract. I think the one they did was not highly professional to see it. Okay. So the report was saying that there is a mature cataract in the eye. What I have to do was to do a UBM, which I didn't do in this case. Yeah, I think in such cases we have to do UBM for better assessment. I think it will show us the sombring ring and will show us the absorbed lens.
Yeah,
but clinically, I thought it was a mature cataract from the pupillary membrane and from the myotic pupil. So this was a mistake, not doing UBM in such case.
All right. It was very well managed. Good luck.
Thank you, sir.
Right.
Thank you, sir. Thank you, Asif, sir. Now, from Egypt, we move all the way to Indonesia. I request Dr. Rizka Yunanda to present the case on ocular surface rehabilitation in pediatric Stephen Johnson. Over to you, Dr. Rizka.
Okay, thank you, Dr. Niranjan. May I share
Yes,
the
please start your screen sharing.
PowerPoint? Okay.
Yes, doctor, just need to go full screen. Perfect. Please go ahead.
Okay, good evening and thank you for this opportunity. My name is Dr. Rizka Yunanda. I'm from Handayani Hospital Lampung, Indonesia. And I will present a challenging pediatric Stephen Johnson syndrome with case with significant ocular complication and the successful outcome achieved through early intervention and innovative adaptation. From the introduction, Stephen-Johnson syndrome is a severe immune-mediated reaction that can lead a devastating ocular complication, especially in severe in children. That early recognizing and timely ophthalmic management play a critical role in preventing permanent visual loss. And current literature strongly support aggressively ocular surface protection during the acute phase. Amniotic membrane, topical steroid, and early lubrication and serum there have shown significant benefit in reducing cicatricals and sequelae. And the purpose of this case report is to show how comprehensive yet practical management and can significantly improve outcome even in a setting of limited resources. From the case presentation, this is a boy, 7 years old, presented with widespread mucocutaneous involvement 2 weeks after taking amoxicillin. Both eyes saw severe inflammatory change requiring urgent interventions. And on ocular examination, both eyes exhibit dense pseudomembranes and also significant epithelial defect and early symblepharon formation. Fortunately, there were no sign of perforation. From the management involved multimodal therapy following current recommendation because of equipment limitation in my place. I fabricated a modified scleral ring using irrigation tubing to keep the fornix open and prevent symblepharon. This provided effective support to the healing process. And by week 4, the corneal epithelium had healed completely. Inflammation subsided and only minimal entropion remained as a long-term sequelae. That importantly, the visual axis remained clear and functional. So this case highlights that timely intervention is more crucial than equipment availability. Even low-cost modification like tube-based scleral ring can prevent severe sequelae when standard devices are not available. Literature strongly support early AMT and lubrication, both of which contribute to our successful outcome. So my learning point here is these are the major clinical lessons learned from this case, emphasizing early, aggressive, and creative management. In conclusion, early and comprehensive ocular management significantly improves the visual outcome in pediatrics SGS. Adaptable technique can make real differences in resource-limited hospital. I think that's all. Thank you.
Thank you, Dr. Rizka, for the wonderful presentation. I think yet again one of the contestants bang on time. Fantastic. Now, I request one of our esteemed judges, Dr. Akshaya Balaji, to share her perspectives on this case.
Hello, Riska. Very nicely presented case. Can you
Hello.
elaborate on the modified scleral ring that you've used in this case? If you
Yes.
have an image, it will be very nice if you can share it here.
Okay. Yes. I'm I use an irrigation aspiration tubing as a modified scleral ring because a commercial symblepharon ring was not available in our setting during the acute phase. This principle of management is maintain fornic depth and prevent early adhesion. Why I choose the irrigation tubing? Because it is flexible, biocompatible, easily shaped into a ring, and provides the same mechanical aspiration between bulbar and tarsal conjunctiva. And so using this modification allow me to follow evidence-based acute SGS management despite equipment limitation. Thank you, doctor.
What is the duration you use this?
Oh, yes.
How long do you use this ring?
Okay, I use this for 2 week. In 4 week after the acute phase on the patient.
Okay. Best wishes. Thank you.
Thank you, Dr. Akshaya. Now, from Indonesia, we go ahead to Mexico. And I request Dr. Emmanuel Franco Gomez to present the case on atypical Achromobacter keratitis in a contact lens wearer. Yes, doctor, we can see your presentation full screen, but
Okay,
you're not
thank
yet
you.
audible. Yeah, now you're audible.
And we can
Please
see
go
Hello,
ahead.
everyone. My name is Emmanuel
India
Franco
to Mexico.
from Mexico.
Hi.
It's a pleasure to join us this session, and today I will present a case of a typical Achromobacter in a contact lens user. I would also like to thank Dr. Prasanna for the invitation. Okay, Achromobacter is a rare opportunistic pathogen. I mean, contact lens related and in keratitis is common, but infection by this organism is unusual and often to manage. In this case, I want to show you the clinical course and microbiological findings. So, on presentation, this case reminds us to always consider a typical keratitis in contact lens user. Microbiology and susceptibility testing were key to confirm the pathogen and getting our final choices. In Mexico, early cognition and target therapy helps us to prevent many complications. Well, the cornea show the marked hyperemia and diffuse estrema. So it's a several case of epithelial defects with counting fingers vision about 10 feet vision. So we followed the case with several photographs, which allow us monitor to disease closely and confirm symptomatic and improvement once treatment was optimized. We performed a microbiological study using a specific media and automatic identification. After 24 to 48 hours, the sample showed a moderate bacterial growth. This was identified like a Chromobacter psilocycines, and everyone was like, what is it? So the susceptibility report showed a resistance to aminoglucoses, but it was sensitive to ceftazidime, imipenem, and others. So the identification allowed us to refine the diagnosis and understand the typical behavior of the infection. So the treatment was actually the initial includes if we see the satellite infiltrates and mixed pattern where we start an empirical therapy with topical moxifloxacin and ethylmycin, and we added a fortified of fluconazole. Um, since in Mexico we don't have voriconazole, not available, so the patient showed a clinical improvement even it was a bacteria, but with this confusion. So we maintain this regimen, and then in this case, contact legs were an exposure to humid environments, like were contributing these factors, and the presence of satelllital infiltratives initially suggests a possible fungal pattern. So, although the specific role of fluconazole remains uncertain, but Acronobacter is a rare opportunistic pathogen. So, and this highlights the importance of the early culture and susceptibility in testing, and timely identification can prevent severe complications. So just in the final, I just want to say this patient contact legs were better, and to conclusion, just thank you for the opportunity to present this case. It was a privilege to learn from colleagues in India, and finally from Mexico and the top of the mountain of the volcano. You see, you will always welcome. Thank you.
Thank you, Emmanuel Franco, for joining us all the way from Mexico despite the time zones. We really appreciate your commitment and dedication for being here. Thank you. Over to the judges for questions. Thank you.
I request Asif sir to share his perspectives.
Yeah. Hi, Dr. Emmanuel. It was a very well managed case. Especially it's very gratifying to see the final corneal picture. So first thing I would like to ask you is like after seeing the culture sensitivity, was the moxifloxacin and ethylmycin changed to any other medications, or
Yeah.
you continue the same medications?
Yeah, I mean, the antibiotics were administered every 2 hours, and even it was sensitive with another medication. We can make um, a fortified of these medications, and this is an opportunity because we don't know if it was just a bacterial, the several bacteria, or maybe a fungical one. But here in Mexico, patients we can pay, and the clinical that we see is like will be a mix. I mean, so she were better and better, and we keep the treatment.
Yeah, I got that. So at the end of the day, we need a proper and a good microbiology department to diagnose these kind of rare infections as well. Good case. Thank you.
Okay, thank you.
Thank you, Asif sir. Now let's go ahead to Philippines, and I invite Dr. Berna Edes R. Lin to present her case on ocular Steven-Johnson syndrome in a pediatric patient. Dr. Emmanuel, if you could please stop screen sharing.
Manjula ma'am, can you help with the
Yes.
screen share? Thank you, Dr. Franco. Once again, can you just stop your screen if it's possible? Yeah, perfect. Yeah. Dr. Berna, over to you for your presentation.
Good evening, doctors. I am Berna Edeslim, a resident physician from Manila Doctors Hospital, Philippines. The title of my case presentation is Scarred for Life, the Need for Rural Awareness in Pediatric Ocular Stevens-Johnson Syndrome. I have no financial disclosures. So this is a case of a 5-year-old female from a rural community who presented with a 7-month history of bilateral eye redness. The history of present illness started 7 months prior to consult. The patient had fever, treated with cephalosporin for UTI. Then 6 months prior to consult, noted recurrence of fever, diffuse pruritic skin rashes, nail shedding, periocular ulcers, bilateral conjunctivitis with eye discharge, photophobia, and occasional eye pain. She was managed at the rural hospital as varicella zoster with conjunctivitis and treated with the following medications. Her rashes resolved, but the ocular symptoms persisted. In the interim, she then consulted with a general physician, given only with erythromycin ointment and lubricants. Yet her eye condition worsened, now associated with whitish corneal opacity and difficulty opening the eyes. Hence, consulted to our institution. Other parts of the history were unremarkable. For the physical examination, VA in the right eye is 10,400 and the left eye is 2032, both not improved on pinhole. Gross examination of both eyes shows inspissated MGs on both lids, slimbefaron, tylosis, and minimal entropion of the left lower lid. Hirschberg pupils and EOMs were normal. The anterior segment examination of the right eye shows severe surface involvement with 360 panus and central corneal scar and punctate erosions, while the left eye shows milder disease with small inferior corneal opacity, inferior panus, and conjunctival keratinization. On dermatologic examination, the skin appears mottled. Given the history and PE, this lead to a diagnosis of chronic ocular SGS both eyes, probably secondary to a drug-related cephalosporin delayed type hypersensitivity, varicella zoster virus, bilateral limbal stem cell deficiency, left lower lid cicatricial entropion. For the management, the patient is currently maintained on eye lubricants. Anti-inflammatory drops to control flare-ups and BCL was also applied to avoid friction-related microtrauma while awaiting definitive management with simple limbal epithelial transplantation. SGS and TEN are severe life-threatening mucocutaneous reactions that cause widespread epidermal and mucosal epithelial necrosis. In the acute phase, many patients develop bilateral conjunctivitis and some progressing to conjunctival or corneal ulcerations, while long-term ocular sequelae may include persistent surface breakdown, chronic dry eye, and scarring. Medical management of acute ocular SGS includes topical antibiotics, steroids, calcineurin inhibitors, and lubricant, and for surgical management includes amniotic membrane transplantation with SLET. For the take-home message, ocular SGS in children may mimic viral illness or simple conjunctivitis leading to a delayed diagnosis. Persistent eye symptoms after a fever rise should raise your suspicion, and delayed referral increases the risk of permanent ocular damage. So early recognition and prompt ophthalmologic evaluation are essential to prevent long-term visual impairment. Because sight lost today is a lifetime lost tomorrow. Thank you for listening.
Thank you, Dr. Berna. Ended with a nice quote there. Now, I request Dr. Akshya to share her perspective on this case.
Hello, Berna. Nice case presentation. I really appreciate you for the choice of case. Uh, in your differential diagnosis, you have written varicella zoster infection. No? Is
Yes.
there any specific reason for that? Do you had any
Yes.
symptoms?
Yes. We did not see the patient because the patient was managed at a rural community back then, 7 months prior. The patient was treated with acyclovir. The patient presented, she gave me the prescription that they are buying the acyclovir, and the managing physician diagnosed the patient as varicella. And when the patient came in our institution for second opinion due to non-resolving bilateral eye redness with difficulty opening the eyes, that's the time that we see that the patient has this SGS, chronic sequelae of SGS. There is tylosis, symblepharon, and keratinization.
Okay. Is there any investigative modalities that are coming up in the future for diagnosing SJS that you know of?
Specific modalities. I think SJS can really be diagnosed clinically and by history alone. So I think we should raise awareness, especially in general practitioners, to be able to not underestimate any viral exanthems and always include in their differentials the possibility of SJS.
But biomarkers, granulysin test, interferon gamma, and all, they're all coming up, and they might really be helpful in the future, even though they are costly. PCR, all these things are always add value because it is very difficult to diagnose SJS, especially in pediatric cases. Thank you.
Thank you.
Thank you, Dr. Akshay, for your valuable insights. I think now we are coming back to India after a long world tour, I guess. So, coming back, first up, we have Dr. Bahubali, and
Yes, sir.
he is here to present a case of phenotypic overlap or coincidence. Over to you, Doctor.
Yes.
Dr. Lala, welcoming you. I think we can see you scrubbed in.
Yes, I'm really sorry. I have an urgent case right now, and that's why I cannot join. But I'm listening to you guys.
Yeah,
I'm really sorry
thank
about
you,
that.
dear Lala. Warm welcome
Yes.
to
Thank
Naadi YOSI.
Welcome, Dr. Lala.
Good luck. Great cases. Congratulations.
Over to you, Dr. Bahubali, please.
Yes.
Go ahead with the presentation.
Good evening, everyone. I am Dr. Bahubali, presenting a case on phenotypic overlap or coincidence, a rare case of Schwartz-Jampel syndrome presenting with Peters anomaly. A 5-year-old girl cell presented to us with whitish opacity in both eyes, right more than left, with complaints of difficulty in opening of both eyes. Whitish opacity was stable in both eyes, associated with decreased opening of both eyes and involuntary eye movements, and no history of trauma, pain, redness, watering, or photophobia in the past. Birth history was within normal limit, immunized till date, and she on pedigree analysis she had an elder sibling who also had similar features with parents unaffected, suggestive of autosomal recessive pattern of inheritance. On general physical examination, she had low hairline, arched eyebrows, low set ears, mongoloid slant, hypoplastic alanacea, long philtrum, and pursed lips. Her elder sibling also had similar features. She had typical mask-like faces. On systemic evaluation, she had microcephaly, short stature, and blood investigations were within normal limit. These typical syndromic faces prompted us to get a genetic evaluation, and we found out heterozygous frame shift mutation in exon 9 and 10 of HSPG2 gene that codes for perlecan, which regulates for acetylcholinesterase levels at the neuromuscular membrane, which is typically seen in association with Schwartz-Jampel syndrome. In our review of literature on ocular features associated with Schwartz-Jampel syndrome, we found out around 150 reported cases. Interestingly, none of these cases had corneal opacity, which raises an important question: is the corneal opacity a manifestation of the syndrome, or could it be attributable to an unrelated condition? On further examination, she had on a examination of the eyelids, she had ptosis, blepharophimosis, and frontalis overaction. On ocular examination, she had central locomotor's corneal opacity in both eyes. In right eye, it's 4x4, and in left eye, 1x1, with iris strands adherent to posterior corneal surface. Lens appears clear and central in both eyes. And posterior segment examination was within normal limit. And anti-segment OCT, as you can see, corneal thickness of 881 in the right eye and 654 in the left eye with iris strands adherent to posterior corneal surface. This raised corneal thickness helped us to rule out any infective pathology. Intraoperative OCT depicting iris strands adherent to posterior corneal surface with posterior stromal opacity and relatively clear anterostromal layer suggestive of Peters anomaly type 1. Her elder sibling had temporally subluxated lens in the right eye and central lens in the left eye with clear cornea. As you can see, temporally subluxated lens in the right eye and central lens in the left eye. A diagnosis of Schwartz-Jampel syndrome with Peters anomaly type 1 was made, and she was planned for right eye optical iridectomy with submental injection of Botox under general anesthesia was planned. With only about 150 cases of SJS reported globally and Peters anomaly occurring at a rate of 1.5 per lakh population, their co-occurrence makes our case exceedingly rare and unique. SJS is a multi-system disorder that mainly affects skeletal and neuromuscular functions with significant ocular involvement. Perlecan deficiency disrupts neuromuscular signaling, leading to overactive motor end plates and contributing to muscle spasm and facial anomaly. Blepharophimosis is the most common eye feature in SJS, causing ptosis and inner eyelid folds. Mask-like facial appearance in SJS is due to muscle stiffness, especially from myotonia and blepharospasm. Orbicular ocular muscle spasm hinder eyelid development, contributing to blepharophimosis. Extraocular muscle stiffness lead to result in diplopia, strabismus, lens dislocation. Our patient also showed signs of Peters anomaly, which are not typically associated with SJS. Peters anomaly arises from abnormal neurocrystals affecting mesenchymally derived structures in the eye. SJS and Peters anomaly have distinct causes, suggesting their co-occurrence in this patient is coincidental, not causally related due to their unique pathogenesis. Thank you.
Thank you, Dr. Bahubali, for the
Yes.
nice presentation. Now I invite Dr. Lippy, if you're there with us, to share your perspectives on this case, please. Okay. If Dr. Lippy is busy, can I invite Asif sir? Asif sir, your 2 cents on this case.
It's a nice and a very rare case, Dr. Bahubali. And I would like to ask you, when you're doing a genetic analysis, was any genes analyzed for Peters syndrome as well, like PAX6 or PTX2 or something?
No, sir, we didn't get any specific test for Peters anomaly, as it is commonly diagnosed with clinical presentation. So we didn't order any.
Just because,
test.
like, is it like a part of SJS, or if it is a separately Peters syndrome that is occurring? So just for that. And apart from that, what are the systemic evaluation that we need to keep in mind when we encounter such cases? Like,
so in SJS, these children, there are 2 types of SJS. One is the milder form and other one is the severe form. In the severe form, they are usually high risk of cardiac anomalies. So we need to get complete cardiac evaluation. So 2D echo and all other ECG, all other tests to be done to look for any cardiac involvement. And complete general physical examination is necessary, sir, for to rule out any other association.
okay, all right. Okay. Great presentation. Thank you.
Thank you, sir.
Thank you, Dr. Bahubali. Manjula ma'am, I think somebody's opened the whiteboard by mistake. Could you please?
1 second, Doctor.
Yes, thank you, ma'am. Over to the next presentation, Dr. Priyanka Mohan. Dr. Priyanka, are you there with us?
I think
Yeah, she's there, sir, but
we can switch on your audio, Dr. Priyanka. Maybe I'll call her up. You can start with the.
yes.
Can move to
Okay.
the next person.
Yes, sir.
I'll call her up.
So, Dr. Siddharth Tyagi.
Good evening, sir. I'm present.
Yes.
Wonderful,
Good evening,
wonderful.
Dr. Siddharth.
Love your spirit.
Loud and clear.
Yeah.
Yes.
Thank you, sir.
Now, Dr. Siddharth is going to present on the bug-eyed patient, exploring the impact of insect-induced keratitis. Over to you, Dr. Siddharth.
Sir, shall I share my screen now?
Yeah.
Yes,
Perfect.
yes, please.
Sir, it's showing unsupported. Screen. Okay, screen I'll share. Yes, sir. Can you see?
Yes. Yes.
Is the presentation visible, sir?
Yes, please go full screen and we can start. Perfect. Go ahead.
Yes. Good evening, everybody. My name is Dr. Siddharth Tyagi. I'm a first-year DNB resident from Pushpagiri Eye Foundation. I'm going to present a case titled The Bug-Eyed Patient, which explores the impact of insect on an ocular surface. So, a 50-year-old male laborer, a resident of Nepal, presented to the OPD with diminution of vision in the right eye 4 weeks after an insect impacted his right eye. It was painful, associated with redness and watery discharge. Vision in the right eye is counting fingers at half meter, while left eye 6 by 6. Corneal sensations were decreased in the right eye. I apologize for the lack of a slit lamp photograph at this stage, but as we can see in the diagram, we can see a 6 into 7 mm large geographical epithelial defect, along with a 3 into 4 mm large paracentral solitary yellowish-white infiltrate that appears to be on the optical section to be at the anterior stromal level, along with DM folds and stromal edema and superficial vascularization. At this point of time, a provisional diagnosis of HSV keratitis with superadded bacterial keratitis was made. Upon review of older reports, it was found out that the patient is a pre-treated one. He rubbed his eyes vigorously after the impact and developed geographical ulcer after 1 week. Vision dropped to 3/60. He was treated with acyclovir eye ointment 3% and 400 mg oral tablets 5 times a day. In 2 weeks, the ulcer increased in size and developed an infiltrate. The vision dropped to counting fingers at 2 meters. At that point of time, scraping revealed gram-positive cocci in pairs and culture revealed Staph aureus. So ciprofloxacin and fortified cefazolin eye drops were added, and sensitivity revealed a ciprofloxacin resistance. So moxifloxacin was substituted. At this point of time, the patient presented to us. So the corneal scraping at that point of time revealed no organisms, and the same treatment was continued. The ulcer worsened and presented with corneal thinning and perforation after 9 days. The right eye vision dropped to counting fingers close to face. We can see in the diagram, the patient presented with a flat AC and perforated cornea. Surgical management was done. A glue with tissue adhesive bandage contact lens was placed along with AC reformation. At 1 week follow-up, the vision in right eye remains status quo. The ulcer has healed with peripheral vascularization and central glue. The bandage contact lens is in situ and removal is advised after 3 weeks. Moxifloxacin and fortified cefazolin eye drops are continued along with frequent lubrication and monitoring. So the question is, why in this case, despite of adequate antiviral and antibiotic cover, the patient progressed to perforation? The patient had no past history of recurring redness or viral episodes in the eye. Trauma to the ocular surface can cause epithelial disruption, facilitating viral reactivation such as HSV, which can become secondarily infected by bacteria. Jason Lee et al. In 2021 found out the role of alpha hemolysin toxin, which is unaffected by antibiotic therapy. It slows corneal epithelial healing and promotes invasiveness to the inner layers, leading to a higher risk of perforation. When the initial response to antimicrobials is suboptimal, we should maintain a high degree of suspicion for atypical HSV keratitis, which can present with stromal infiltrate, and infrequently it can lead to corneal perforation as well. A few case reports advocate a low-end method like GIMSA staining to visualize multinucleated giant cells with characteristic molding of the nuclei, as seen in the first image, followed by the confirmation with a high-end method like PCR or immunoperoxidase assay, as shown in the second image, showing HSV1 positivity in conjunctival cells to diagnose atypical HSV keratitis, established by Atmanathan et al. In 2001. In post-insect injury or soil-contaminated injuries, Bacillus cereus is specifically highlighted, but the difference is it is capable of causing rapid corneal abscess and perforation, and the course is very aggressive. Within a few days, it can lead to corneal perforation. The presence of ring infiltrates can suggest atypical microbes like Moraxella or Acanthamoeba, suggested by Barash et al. In 2017. These are my references, and thank you so much.
Wow, Dr. Siddharth, I think well in time. Thank you so much.
Yes, sir.
For the wonderful case presentation. Now, once again, yes.
Dr. Akshay Balaji for your comments, please.
Hello, Dr. Siddharth.
Good evening, ma'am.
Show me your first slide, which had the diagram.
Okay, ma'am. 1 second. This one.
Yeah. So, how did you come to the diagnosis of HSV keratitis with superadded bacterial at this place? What made you think of this diagnosis?
Ma'am, the epithelial defect was geographical in pattern and its bed was stained with fluorescein as well, along with the margins. So that gave the hint that it could be HSV keratitis, while the infiltrate was yellowish white in color, ma'am. So that gave us a hint that it could be bacterial infiltrate at the anterior stromal level.
Was there any AC reaction?
No, ma'am, AC was quiet at that time.
Okay. So why before your scraping, all antibiotics were discontinued for how long?
No, ma'am. Unfortunately, we were not able to go on a drug holiday, and the patient was on constant antibiotic cover while we did the scraping.
So that might have caused misdiagnosis also, no?
Yes, ma'am.
Since scraping was any occupational history in this particular case?
Ma'am, I think the patient was a farmer, but no, ma'am, nothing for occupation specifically. I don't think so, ma'am.
How do you say that it is an insect-induced keratitis then?
Ma'am, the close,
Anything specific you like to highlight because your topic is a bug-eyed patient?
ma'am, as we discussed that the trauma following an insect can lead to HSV reactivation, ma'am. So the close proximity of these events, like developing the geographical ulcer immediately after an insect impact, that could be the cause, ma'am. That suggests that the impact of the insect could reactivate the HSV.
I haven't heard that. Okay, thank you.
Thank you, ma'am.
I think Dr. Priyanka is there.
Yes, sir.
Yeah, you can. Dr. Siddharth, can you stop your slide share, please?
Okay. Should I put on my slides or should I
Stop
open?
slide
Yeah,
share.
I think
Okay.
you should
Okay.
stop the screen.
I stopped, sir.
Thank you, Dr. Siddharth.
Dr. Priyanka, you can start your slide
So do
share.
we have the presenter, Priyanka?
Yes, sir.
Yeah, it's ready. Timer. Yeah, timers.
So I'm presenting a case of decompression retinopathy, which is a rare complication following trabeculectomy surgery. My patient was a 26-year-old female patient who came with complaints of gradual onset, progressive diminution of vision in the left eye over the past 4 months. And she complained of worsening of vision in the left eye over the past 2 weeks and was also associated with mild pain. She gives history of outside consultation where she was told to have increased pressure in the eyes and started on eye drops. And when checked, it was 4 anti-glaucoma medications in the left eye and 1 in the right eye. She gives history of colored halos. However, there was no redness, watering, headache, or history of any steroid intake or topical medication usage. She gives history of spectacle usage since 16 years of age for distance vision, and it was last changed 2 years back. Her medical history, she gives history of amenorrhea since the past 7 months, and it was a booked pregnancy. She has history of 2 uneventful past pregnancies as well. She had no known comorbidities and no significant family history. There was no history of any ocular surgery or laser. On her general physical examination and systemic examination were within normal limits. Her abdomen examination showed a fundal height corresponding to 32 weeks of gestation, and fetal heart sounds were present. Coming to ocular examination, her uncorrected vision in the right eye was 612 and left eye was 624. And on refraction, with a correction of minus 1.25 sphere and 1.75 cylinder, she improved to 6 parts in the right eye. However, left eye had corneal edema and a dull glow on refraction. Her ocular examination, the anterior segment was within normal limits in the right eye, and left eye showed microcystic epithelial edema and stromal edema as well. The IOP by Goldman applanation was 18 millimeters of mercury in the right eye, in which she was using 1 anti-glaucoma medication, and it was 38 millimeters of mercury in the left eye, in which she was using 4 medications. The rest of the anterior segment was within normal limits. On gonioscopy, both the eyes showed open angles with structures visible up to the scleral spur. Her trabecular meshwork was moderately pigmented and also showed prominent iris processes. This was a right eye, and this is the left eye, although it was hazy because of the corneal edema. Coming to the fundus examination, her disc cupping was 0.4 in the right eye and 0.6 in the left eye. And rest of the fundus was within normal limits. There was no evidence of any RNFL defects or disc hemorrhages. C fields were done. In the right eye, she had high fixation losses. And in the left eye, showed superior and inferior arcuate defects. Her OCT RNFL in the right eye was normal, and the left eye showed thinning in the superior and inferior quadrants. A diagnosis of juvenile open-angle glaucoma was made. Then we attempted an SLT 360 degrees, but it could not be completed due to the media haze. And IOP remained high, 46 millimeters of mercury, because of which she was taken up for trabeculectomy surgery the next day. And post-trabeculectomy, her IOP dropped to 13 millimeters of mercury in the left eye. So this is on post-op day 7. We can see the PI and the bleb that was well formed. On fundus examination on post-op day 7, it revealed decompression retinopathy with multiple superficial hemorrhages in the fundus along with choroidal folds and choroidal detachment. It was observed, and on post-op day 14, 2 weeks after the surgery, we can see that the hemorrhages were resolving nicely. And following that, her vision also improved to 6:12 and with correction to 6:6. And fundus was resolved back to normal 3 weeks post-surgery. Thank you.
Thank you, Dr. Priyanka. That was a very nice case presentation. Now, one second. Yeah. Now, can I invite Dr. Lippy to share her perspectives on this case, please? Dr. Lippy? Okay.
Dr. Lala, if you are available, can you share your comments, please? No, I don't think. I think Dr. Arshi can give your comments.
Yes, Dr. Arshi, please.
Yeah, hi, Dr. Priyanka. Good presentation. So, quick question to you. The patient presented to you at 32 weeks and the pressures were very high. You did attempt an SLT, but what was the immediate measures that you took for IB reduction? And what were the precautions that you could have taken to prevent this ODR from happening?
Since she was already 32 weeks of gestation, we were it was still safer to use alpha agonists. So topical medications could have been used. And also, since she was pregnant and there's a risk of side effects, it is always preferred to do a laser procedure before going for oral drugs to reduce the intraocular pressure. And since it did not reduce even after the attempt, we went for the surgical management.
Did you give any IV drugs or any oral drugs to decrease the intraocular pressure? Mannitol is absolutely not contraindicated in such patients, especially given under supervision. You could have an obstetrician advice taken, and if the fetal parameters were normal under your hemodynamic monitoring, you could give an mannitol to this patient. Also, a controlled paracentesis done a couple of minutes before the surgery could have prevented the ODR from happening, and thereafter you could have proceeded with your glaucoma surgery.
Yes.
What are other indications of doing a controlled paracentesis, Dr. Priyanka?
Preoperatively uncontrolled high IOP, which with shallow anterior chambers.
Anything else? Any stage of glaucoma that you would specifically like to mention?
Advanced glaucomas.
All right, thank you.
Thank you, Dr. Arshi, for your valuable inputs and the nice questions. Now, I would like to request Dr. Aditya Varman sir, who is also one of the dynamic executives of YOSI and very much a part of our organizing team of Naadi. Sir, kindly take over the session for moderation, if that's okay with you, sir. Thank you for joining us and requesting you to.
Okay.
I think sir is a little busy.
Yeah, okay, maybe.
Okay. Until he joins, let me invite the next presenter for today, Dr. Snehita M, and requesting her to present the case on pseudoexfoliation glaucoma with infratemporal BRVO. And the presiding judge would be Dr. Ashi Singh in her realm of specialty of glaucoma.
Good evening, sir.
Aditya is here. Yeah. Okay, Dr. Snehita, start.
Yes.
Please start, doctor. Please go full screen.
When pressure meets perfusion, managing a case of PXF glaucoma with BRVO and cataract. A 72-year-old male, a daily wage laborer by occupation from Virupuram, came with the chief complaints of diminution of vision in both the eyes for 1 year, left eye more than the right eye. The patient was apparently normal 1 year ago, after which he developed the symptoms, and there was history of glare present for 6 months. There was no other positive history like distorted vision, colored halos, or spectacle use or headache, and there was no family history as well. Treatment history was insignificant. There was no history of steroids. And medical history, he was newly diagnosed hypertension, not on any medications. There were no other comorbidities present. The general and systemic examination were within the normal limits. An ocular examination, head position was erect and eyeball position was orthotropic, and extraocular movements were full and free. Coming to the right eye examination, the uncorrected visual acuity was 660, and on refraction it improved to N12, and the adnexa was normal in the right eye, whereas the pupil was 3 mm D plus brisk and C plus sluggish. The vision was explained by the immature senile cataract in the right eye with NO2, NC2, C2, P0 grading with 7 mm mydriasis, and the intraocular pressure was 13 mm Hg. Whereas in the left eye, the vision was 1 by 60 PR accurate and the refraction had a dull glow. The adnexa was within the normal limits, the anterior chamber was quiet, and the iris was normal in color and pattern. The pupil had grade 2 RAPD and there was PXF noted at the pupillary margin. The lens had immature senile cataract of NO3, NC3, C2, P0 grading with PXF zone 3, and the intraocular pressure by GAT at 10 am was 54 mm Hg. This was a right eye slit lamp examination, which was just a senile cataract. This was a left eye examination showing the PXF with the pupillary margin. And this was a dilated left eye fundus examination showing PXF zone 3. This was my right eye gonioscopy using 1 GM Goldman mirror. So it was open angles of 3 using modified Sharper's grading. And in the left eye gonioscopy, it was again open angles of 3 with the sampulosis line noted in the nasal and the inferior quadrant. There was no other evidence of peripheral anterior synechiae or NBA. And the right eye fundus examination was, the disc color was normal, the size of the disc was 1.69 and the NR was healthy with 0.6 up disc ratio. And the temporal peripapillary atrophy alone was noted, the rest vessels and periphery were in normal limits. Whereas the left eye media was hazy because of the cataract, and there was a cup disc ratio of 0.7:1 with NRR thinning noted superiorly and inferiorly. Also in the right eye and in the left eye, both AV crossing changes and AS to V ratio of 1:3 was present. And the infratemporal quadrant had intraretinal hemorrhages, which was present, more commonly attributing to infratemporal BRVO. Some macular exudates were present as well. So my provisional diagnosis would be both eye immature senile cataract with left eye pseudoexfoliation glaucoma, with left eye infratemporal branch retinal vein occlusion with both eye grade 2 HTR. So OCT RNFL was done. The left eye signal strength was just 3/10, so it was not reliable. And the CCT was within normal limits. OCT macula showed 450 micrometers in the left eye macula and there was exudation present. C fields, the patient had high fixation loss. This was the first time he was doing the C fields. So my management was, first we gave injection mannitol 200 ml IV stat. This was because his IOP was very high at 54 mm Hg. Then we sent him off on medications like brimonidine, timolol, and 2 tablets of diamox stat followed by QID. 1 week later, when he reviewed, his IOP had been reduced to 35 mm Hg and we did an SLT. And again, when he reviewed, his IOP was 25 mm Hg. So we did left eye phacotrab with PCIOL under LA. And following visit, we did FFA and noted confirmed the infratemporal hemorrhages and then the NVE and did left eye sectoral laser. So at the end of 3 weeks, his vision was 612 and the intraocular pressure was reduced to 18 mm Hg with a bleb formed and the anterior chamber formed as well. So my takeaway points here are, when there is PXF, expect surprises from zonular instability to vascular fragility to glaucoma. This highlights the therapeutic complexity requiring dual management and surgical finesse in most cases. An intersection of glaucoma with vascular disorder emphasizes the systemic and holistic management. Thank you.
Thank you, Dr. Snehita, for the wonderful presentation. Requesting Dr. Rashi to share her perspectives, please.
Very interesting case, Dr. Snehita, and very well presented.
Thank
So
you,
I
ma'am.
have 3 questions for you immediately. First is, how would macular edema in the presence of BRVO actually influence your choice of AGM or surgery? What would your protocol of management be, the retina first or the glaucoma first? The second thing would be, what is the ring that is formed in pseudoexfoliation named? And the third thing is, how in your hemorrhages, the picture that you had showed, the fundus picture, you only had them to the mid-peripheral retina. You did have a corresponding macular edema. So what could your other differential have been on the basis of just the hemorrhages?
So, ma'am, the first question being based on the macular edema and AGMs, we would avoid prostaglandin analogs because it's attributing to more macular edema. But then here, since the glaucoma and the cataract was also predominant, so we went in for phacotrab. We had an idea of giving anti-VEGF along with phacotrab as well. But then since the patient was a glaucoma case, we just went in for phacotrab, followed by we can wait since till the corneal edema resolves and do a FFA and confirm a diagnosis, and then go ahead with doing a sectoral laser. And then the ring and pseudo exfoliation, no? The
So
question second.
yes, the
Uh,
target sign, what is it also called?
the
That's okay, you can
bullseye,
skip it if you don't.
bullseye
All right.
sign.
No, there's another name for it. That's okay. So in management, as far as what we discussed, so
Yes,
give
ma'am.
as much medical management if you could, and I would have actually preferred the anti-VEGF being given first or a sectoral laser being done first before you actually went
Yes,
to it
ma'am.
with the
Yeah,
phacotrab.
you're exactly right, ma'am. We
Or
also
you could
thought
have
about that, but the
combined,
thing was,
yes.
the cataract was very much dense, ma'am. So the view was also very less. So we were not sure about giving sectoral laser
Even if you'd given an
before.
anti-VEGF beforehand with just intraocular pressure control conservatively, might have
Yes,
helped.
ma'am.
However, it is again a surgeon preference, but
Yes,
usually
ma'am.
you prefer to address the macular edema along with a conservative management of the intraocular pressure before you
Yes.
proceed with the surgery.
Okay,
And your
ma'am.
third question was, what are your other differentials for the IT-BRVO that you showed if the hemorrhages were more centered at the
It would have been
mid-periphery?
just a grade 3 HTR as well, ma'am, because the patient already had AV crossing changes and AS to V ratio of 1:3. So with hemorrhages, but since the other eye was not, generally HTR will present symmetrically, but we can have a grade 3 HTR as also a differential diagnosis in this case, ma'am. Apart from that, just
Ocular ischemic syndrome. And this patient has asymmetric involvement and also has
yes, ma'am.
pseudoexfoliation. Does have macular edema, but yes, you could have also thought about that. Thank you.
Yes, ma'am. Thank you, ma'am.
Thank you so much, Dr. Ashi, for those very relevant and wonderful questions. Now, Dr. Snehita, if you could please stop screen sharing.
Yes, ma'am. Yes, sir.
I invite Dr. Apurva to present her case on from melting to mending, early detection and treatment in pythium keratitis. Manjula ma'am, if you could just help her with this. Yeah, thank you. Thank you, Dr. Snehita.
Good evening, sir. I'll just share my screen.
Yes, yes, Dr. Apurva. Yes. Yes, you're good to
Sir,
go.
is
Please
my
start.
screen visible?
Yes, yes, yes.
Good evening, everyone. I'm Dr. Apurva, first year DNB resident at Sri Ganesh Vinayak Eye Hospital, Raipur, and my topic of presentation is from melting to mending, that is early detection and treatment in pythium keratitis. A 55-year-old female resident of Raipur came with a complaint of pain, redness, watering, and blurring of vision in the left eye since 5 days. Pain was severe in onset, along and discharge was watery in nature. Patient was systemically well and there was no history of similar complaints in the past, any ocular trauma, ocular surgery, foreign body injury, use of contact lens or topical medications. But there was history of doubtful exposure to the contaminated water that was present 1 week back while washing clothes. In ocular examination, visual acuity of the patient in the right eye was 6:6 and the left eye was counting finger close to face. In the adnexa, there was mild lid edema and erythema that was present in the left eye. All the findings are normal in the right eye, but in the left eye, circumciliary congestion along with the congestion of the palpebral and pharyngeal conjunctiva was present. In the left eye corneal examination, we could see that the cornea was normal in shape and size with the loss of transparency, and there was a vertically oval, dry looking grayish white stromal infiltrate of a size of around 6.4 millimeter into 6.4 millimeter with about 50% of the depth, and the epithelial defect overlying it of 6.4 millimeter into 4 millimeter. There were characteristic stromal infiltrate with hyphated edges. That test shows pinhead shaped lesions with tentacular extension, and corneal edema was present with DM folds, and sensations were normal in all the quadrants. All other anterior segment findings were within normal limits. Right eye fundus was normal and the left eye fundus could not be visualized because of the corneal edema, hence left eye B scan was advised. And that came out to be completely normal. In the keratitis workup, slit lamp imaging was done and the blood sugar level was checked, which was 122 milligram per DL, and the syringing was patent in both the eyes. Corneous clipping was done under topical anesthesia, and on 10% KOH, it showed long, broad, sparsely septate filaments, and on gram staining, it showed thick cell wall with ribble-like patterns. Both of them suggested of pythium keratitis. And empirically, we started the patient on azithromycin 500 mg once OD once the baseline ECG was done, and the eye drop natamycin 5% 1 hourly started along with azithromycin 1% 1 hourly and homatropin 3 times. Pythium hyphae completely mimic fungal hyphae, and it becomes challenging to decide on the drug of choice based on just clinical picture alone. Thus, antifungal were started before culture results came. At 48 hours follow-up, culture confirmed the growth of the pythium species and shown as flat, feathery-ish, partially submerged hair-like projection on the blood agar. Hence, the diagnosis of left eye pythium keratitis was established, and patient was started on targeted therapy with tablet azithromycin 500 mg once daily for 14 days, and eye drop azithromycin 1 hourly, linezolid 0.2% IV preparation 1 hourly, and homatropin eye drops. In the third follow-up, that is after 5 days of targeted treatment, size of the infiltrate and the epithelial defect decreased with furrowing that was present temporally and the superficial vascularization. And on further follow-up, scarring was present and thinning was there with more than 50% of the depth was noted along with the hypopyon, and hence tissue adhesive was applied with BCL application. And doxycycline was started in the patient keeping in mind collagen lysis due to the drug toxicity, and the same topical medication was continued with decreased frequency. And 1 week status post TABCL, the thinning was stabilized, there was no hypopyon, and treatment was continued with the frequency of eye drop to decrease to up to 6 times. After multiple follow-ups and the close monitoring in the sequelae, the TABCL removal was done and the keratitis healed with scarring and deep vascularization with vision up to 1/60 in the left eye. The take-home message from this slide is that even though pythium is great mimicker, always look for characteristic clinical sign. Microbiology is must, and you should always act faster than the pythium as it causes Graves' ocular morbidity. Thank you.
Next presentation, Doctor.
Thank you, sir.
Yeah. So we will invite Dr. Asif sir for a comment, please.
Dr. Apurva, it was a very nice presentation. So it was a very characteristic clinical picture. We could see the tentacular lesion. So I mean, like, it was a very well managed case, and it has been done very nicely. And I like to ask one question. If you are planning a therapeutic penetrating keratoplasty in these cases, how is it going to be different compared to the other infective keratitis?
So the grafts, when we are trephining the graft, the size that we take, we usually take the larger size because of the role of the limbal spread that is there in these cases, in the pythium cases, and also the recurrence is very common in the grafts also that is reported with pythium. So we always have to keep that in mind as well.
Yeah, that's a very valid point. So you have to take slightly on the larger margin, should be around like 1.5 millimeter, because there are higher chances of recurrence and early limbal involvement can be there. Yeah, great. Thank you.
Thank you, sir.
Thank you, sir, for your valuable comments. Now I will hand over to Dr. Aditya, one of dynamic executive and one of the co-organizer for this competition, to take over moderation.
Yeah, thanks, Karthik. So I'd like to introduce the next contestant, Dr. Meher Gupta. She's going to be talking about from perforation to recovery, a challenging case of AGV-related complications. Over to you, Dr. Mehek.
You can start your slides. Yeah.
Please share your slides, madam. Yeah.
Timer, please.
Sir, are my slides visible?
Yes, visible, doctor.
Good evening, everyone. I am Dr. Mehak from Guru Nanak Eye Center. I am going to present from perforation to recovery, a challenging case of AGV-related complication. A 40-year-old male presented to emergency with complaint of increasing pain and watering in right eye for 1 day. When we asked the past history, patient had 10 years ago right post-traumatic cataract surgery with IOL drop, followed by PPV with IOL explant with AC IOL. Patient had moderate gain of vision. 3 months back, patients started having gradual loss of vision in right eye to finger counting 1 meter PR accurate. On examination, there was pseudophakic bullous keratopathy with corneal scarring with secondary glaucoma in right eye, and left eye has PAC. So medical management was done and YAG laser PI was done in left eye. Due to the uncontrolled IOP and multiple peripheral skynicae and scarred conjunctiva, right AGV implantation was done. Post-operatively, IOP was controlled, tube was put in sulcus, it was a vitrectomized eye, and patient was on tapering prednisolone. This is the second week post-op image of the patient. Presently, when patient presented to emergency, it was a 4th week post-op patient. Patient had BCVA of hand movement close to face, PR accurate in right eye with shallow AC. And there was a perforated corneal ulcer 2 into 2 mm with infiltrate at 6 o'clock, 3 mm from limbus. Serial was positive and there was 360-degree peripheral anterior synechium. IOP was also low and fundus couldn't be seen. Hence, right eye glue with BCL was done the next day. On culture and KOH, fungal was positive, but there was decreased corneal sensation also. So patient was started on fortified Cefta, Vanco, Natamet with atropine and steroid was stopped. At day 5, patient had hypotony with choroidal detachment. Ulcer was healing, but we need to start steroids for the choroidal detachment. Hence, after corneal referral, oral steroids were started under antibiotic and antifungal cover. However, corneal detachment worsened and there was retinal detachment also. So diflupred was added. However, retinal referral was done and nil intervention was suggested. But due to the increased hypotony, AGV tube ligation was done with Vicryl 60 and 80 nylon suture near the tube plate. Post-operatively, RD and CD persisted and there was no change. Hence, right vitreoretinal surgery with silicone oil insertion with endolaser was done. After 1 week, IOP spike was there and there was pain and heaviness. IOP increased to 40 millimeters of mercury and there was a tenon cyst formation. Hence, AGV tube ligature was removed and bleb needling was done. During needling, we found that silicone oil was there near the plate. Following which, RD was resolved and bleb was okay and IOP also normalized. So what went wrong? Scarred cornea could be because of an old viral keratitis, which predisposed to secondary infection after steroids post-AGV surgery, which prone the patient to corneal perforation. ACIOL in a PAC or PCS eye can lead to pus formation, which can in turn lead to a glaucoma. Tube removal could have been attempted in this case because gross hypotony was a deterrent, but again it's a surgeon's choice. Multiple insult and ciliary body shutdown was additive. In review back literature, we found one case of similar finding. Conclusion, steroid use with poor cornea or old keratitis might predispose to ulceration, and multidisciplinary care can improve patients' visual outcome and anatomical outcome. However, not all cases are surgical success. Thank you.
Thank you for that presentation, Dr. Mehak. I'd like to invite Dr. Arshi Singh for her comments on this presentation, please.
Dr. Mehak, well presented. This was a very challenging case. So as you said, you thought that the predisposing factors were the fact that the patient could have had a prior viral illness. What all pre-op investigations would you have liked to have done in this patient?
Ma'am, in this patient, if we would have carefully examined the cornea, then there might be vascularization present. Also, we should have done corneal sensation. Pre-operatively, we should have checked corneal sensation. If they were decreased, then it again indicates that patient might be having a viral keratitis earlier. And then we should have asked history to the patient about the recurrent redness present and the signs present in the other eye also.
Post vessels or any prior opacity that was there in this patient? I understand that he came to you after having multiple surgeries, including a pars bina lensectomy as well as for an IOL drop. So
Yes, ma'am. There was a slight corneal opacity present in the patient, which we ignored and we didn't think that it might be an old viral keratitis.
So what all other AGV related complications are there, and what is a case where you would like to remove the explant immediately? What would that indication be?
Yes, ma'am. Other AGV related complications can be hello,
Yes, you're audible.
am I audible?
Yes.
Yes, ma'am. Other AGV related complications can be because of a valve device or a non-valve device. In a valve device, there is a decreased chance of hypotony, but in a non-valve, there is increased chance of hypotony present. Then there can be high FEMA or shallow AC. Then there can be choroidal detachment or retinal detachment. Risk of endophthalmitis is also there. Then because of the tube, there can be tube dislocation or tube extrusion, or tube might touch the endothelium, which can lead to corneal decompensation. Tube might get blocked because of a vitreous or silicone oil or any other debris present. Then there can be tube retraction, which can occur. And also, since uh, we we put the AGV between the two muscles, it can lead to diplopia also if the plate is large. So these are the complications. And ma'am, if there is kissing choroids present or there is too much hypotony, then we can consider removing the tube instead of doing tube ligation.
All right. Thank you, Dr. Mehak.
Thank you, ma'am.
Yeah, so we'll now move on to the next speaker. Is Dr. Ankur Biswas ready with this presentation? He's going to present to us on ocular findings as the clinching points for diagnosis of Alport syndrome. Over to you, Dr. Ankur. Please do share your slides now.
Can you all able to see the slides?
Not yet. Have you started sharing it?
Yeah. Can you?
Not yet. It says it has just started. Just give it a second. Can you try it again? Yeah, it's come now. Okay.
Okay. Good evening to one and all here. This is Dr. Ankur Biswas, first year postgraduate from Meenakshi Medical. Would about to speak up with the topic ocular finding as the clinching point for
Doctor,
diagnosis
could
of
you please
Alport
go
syndrome.
full screen, if that's okay?
Can you start
Yes.
in presentation mode, please?
You need to go to slideshow.
Yeah.
Click it and start from
Can
first
you
slide. Yeah. Go to take your point to slideshow.
Yeah, it's already been done in the slideshow.
No, you're not in presentation mode. There's an icon there on the bottom right-hand side corner. You'll have to click it to go into presentation.
Yeah, I've already done that.
Okay, can you move it and share? No, your mouse is moving. Yeah. One thing you can. Yeah.
Yeah, exactly. Yes. Yeah. Please start now.
Yeah. Good evening to one and all here. This is Dr. Ankur Biswas, first year postgraduate from Meenakshi Medical College. Would speak of the title ocular findings as the clinching point for diagnosis of Alport. So a 19-year-old male came with both of vision for last 5 years. Systemic complaints include easy fatigue, vomiting, abdominal pain for last 2 months, and bilateral hearing loss for last 5 to 6 years. No other specific ocular complaints.
Dr. Ankur, your slides are not visible, at least to me. I don't know if they're visible to the others.
Yeah, the slides are not visible.
Now it's moving. Now it's moving, Dr. Ankur. Yeah. Actually,
Now
it's
visible.
moving, right?
Yes, now visible. I can see the history slide.
Perfect.
Yeah. It's a known case of hypertension, which is newly diagnosed, which is not on treatment. Spectacles usage for last 5 years. What specs, but he was not using regularly. And there is no history in parents and siblings of similar type of complaints. But paternal grandfather had bilateral lower limb swelling, which was might be due to dental failure, this thing. But before he passed away. Then move on to the local examination. BCVA 6 by 12 partial with N8 with myopic correction. IOP right eye is 13, left eye is 12. Color vision both were normal. EOM full and free in both eyes. Lids normal. Conjunctiva healthy. Cornea clear. Anterior chamber normal depth VH3. Iris normal color and pattern. pupil both reacting to the light, and lens right hand side show capsular cataract with posterior polar cataract, and left side. Then we move on to K reading. K1 value of the right eye was 44, whereas for the left eye was 43.5. K2 was 45.5 for the right eye, 45.5 for the left eye as well. Axial length was 25.36 right eye, and for the left eye 26.6 mm. IOL part was plus 14 diopter in the right eye and plus 11 diopter in the left eye. Lens thickness was 3.9 in the right eye and 3.5 in the left eye. Fundus examination showed dilatation was 7 mm. Mean right eye hazy due to lens
Dr.
changes.
Ankur, your slide is not moving a bit. I think there is an internet glitch.
So it's not moving, sir?
Yeah, it's in K reading only. Now it's moving. Yeah, fine. Now it's now we can move.
Okay. So media was hazy due to lens changes. Left eye was clear. Risk 0.2:1 HNR in the right eye, and the left eye was 0.3:1 HNR. Margins for both eye distinct. Vessels were arteriolar attenuation plus. Background were mild peripheral tessellations, and macula showed right eye FR dull and left eye FR. This is a slit lamp exam showed the both eye anterior lenticonus, followed by the first picture. As we can see here in the fundus picture, a central plaque retinopathy is present around the macula. So my diagnosis is right eye anterior subcapsular cataract with posterior polar cataract with both eye anterior lenticulus with both eye central plaque treatment as like this is a genetic report which confirms call 4A5 positive. So this is case of Alport syndrome. So in case of treatment, first we treat cause that we treat the Alports with help of ACE inhibitors like lisinopril. And for eye, the definitive management for ocular manifestation is phacoemulsification or other. We put new IOL as. My take-home message is that presence of ocular manifestation along with systemic manifestation of the disease not only confirms with Alports, but we can able to rule out the type of genetic disorder in by seeing the fundus of the mother or female member of the predecessor generation, thus limiting the role of genetic analysis tests and saves a lot of money for those who rarely afford it. And hence, ophthalmologists can to take the manifestation and initiate the treatment as soon as possible.
Okay.
Thank you. Judges,
Thank you.
requesting you to.
Can we have Dr. Akshay Balaji for the
Adit, 1 minute. Sorry, I'm interrupting. Judges requesting you not to mark negative for the timing. He was right on time because of the technical glitch. His presentation was 4 minutes. Yeah, over to you, Dr. Adit.
Yeah. Thank you, Doctor. I'd like to invite Dr. Akshaya Balaji for her comments on the case.
Hello, Dr. Ankur. Due to technical glitch, I was not able to follow a lot of things here. Can you please show me the slit lamp findings alone? Just one slide, please.
Ma'am, can you able to see, ma'am?
No.
Now?
No, it's in the thank you slide. I don't know if others could see. I am able to see only the thank you slide. Okay, no problem. What were the retinal findings you mentioned?
In this case, I able to we central flare retinopathy, ma'am.
What other retinal findings you expect in case of Alport syndrome?
Ma'am, in case of Alport syndrome, along with central flake retinopathy, peripheral flake retinopathy might be or might not be present, along with macular hole, also macular. As we told in the take-home message that we can check the female predecessor or mother of the predecessor generation. So
No.
if we
Retinal
see,
findings, please stick to that. Other retinal findings, one you said was flake retinopathy. Then?
Ma'am, then
Macular hole, did you do an OCT to rule out or a 90-day examination?
Yes, ma'am. I spoke about the OCT, ma'am, but the thing was very couldn't able to afford it, ma'am. So we can't able to do OCT, ma'am.
Okay. Temporal retinal thinning is also an important finding in Alport syndrome, uncle. And significant family history was there in this case?
No, ma'am. Significant, like clinical significance, nothing was there, ma'am. And his mom didn't with him, so we couldn't able to see what were the retinal changes in the. Otherwise, we could have ruled out it was X-linked or autosomal recessive.
What systemic findings were you able to elicit in this case?
Systemic findings of the patient was easy fatigability, ma'am, abdominal pain, vomiting. The systemic findings.
Renal features and hearing loss. That's all.
Yes, ma'am. Renal like hematuria and bilateral hearing, sensory neural hearing.
Sensory neural hearing loss. Systemic investigations that were you did in this particular case after your ocular diagnosis.
Like, ma'am, it was a referral case, ma'am, from the general medicine. So they did that, ma'am. But photo, ma'am.
No, I don't want
I,
photo. So
but
ultrasound
we did
abdomen and other
systemic
things were ruled
investigation.
out.
Hemoglobin, yes, ma'am. Hemoglobin was IFT was leading. UR was around 56 and it was around 1.8, ma'am.
Okay, all right. I think due to technical glitch, I was not able to hear very clearly. But yes, in Alport syndrome, it is important to have a multidisciplinary approach, and the ocular findings will help in ruling out life-threatening renal diseases. Thank you.
True, ma'am. Like my point here was to like genetic analysis cost around 3,000 to 3,500. This case it cost. So we did with our own pocket, ma'am. So like not all patients can able to afford it. So without my point was that without going to the genetic analysis, the systemic manifestation, and also with the ocular manifestation, we are not able to go into the Alports and also onto the type of Alports, ma'am.
Okay. Thank you, Ankur.
Right. Thank you, Dr. Ankam. So next will be, sorry, the next speaker will be Dr. Ankam Sai Akil,
Yeah,
who's
hi,
going to be presenting a case of peripheral ulcerative keratitis secondary to rheumatoid arthritis. Please do share your slides, doctor.
Manchila ma'am, can you help and stop the slide share? I think there's some problem.
Sure, doctor.
Thanks, ma'am.
Yeah, you can share your slides, Dr. Ankam Sai.
Is it okay? No? Hello?
Not yet,
No,
not yet.
not yet, not
Not
yet.
yet. You have to bottom there'll be a button called a share, and you can share your screen and start opening work.
Is it okay now?
Not yet. Are you able to click the share button?
Yeah, yeah.
You're not after clicking it, you can, yeah. Now your screen is shared. You can start the presentation. Yeah, you can start.
Good evening, everyone.
Start a timer.
Title of my topic is Theory Red Eye, a battle against immune system. I myself, Dr. A. Sayakil, my mentor is Dr. Raghav Pritam. A 40-year-old lady came with a chief complaints of pain, redness, and loss of vision in right eye since 5 days. She is a known case of rheumatoid arthritis positive, but not on any treatment. She was referred for evisceration. On examination, we can see a classical swan neck deformity in both the hands and in the left leg. This is the picture of the right eye where we can see a 270 degrees corneal perforation where iris contact was made more nasally and with the active infiltrates and the central corneal edema and streak hypopyon is noted and the anterior chamber was peripherally shallow. This is the picture of the left eye where the vision was PL positive. There is adherent glaucoma at 5 o'clock and the cornea thinning and desmodocele at 10 o'clock position and dry filaments on the cornea Conjunctival congestion is also seen and mature cataract is also seen. So we have a differential diagnosis. We came to a differential diagnosis of peripheral ulcerative keratitis, Sjogren's syndrome, and infective keratitis. Investigations where the high increased levels of ESR and rheumatoid factor were seen, and the viral serology were negative, and scrapings were also negative. The provisional diagnosis of my case are OD corneal perforation with peripheral ulcerative keratitis, OS, resolved PUK with severe dry eye with adherent glaucoma with mature cataract. Treatment plan, patient was started on 3 doses of IV methylprednisolone 500 mg and IV cyclophosphamide 500 mg, IV mesna 200 mg. IV mesna was given prior IV cyclophosphamide and after the IV cyclophosphamide. So this is the uh, video where this is the conduct. Initially, we have performed epithelial debridement of a 2 clock hours and followed by conjunctival resection lateral margin to the infiltrate till 4 mm beyond the limbus. After excision, cyanoacrylate glue was applied. After the application of the cyanoacrylate glue, we placed a bandage contact lens, which is shown here, and we have performed lateral paramedial tarsorrhaphy. And we have started the patient on tear substitutes, moxifloxacin, prednisolone, and cyclosporin 0.9% 2 times a day. For the treatment of the left eye, we have started around a tear substitute, prednisolone, and cyclosporin 0.92% a day, and systemically advised IV cyclophosphamide 500 mg monthly once and tablet hydroxychloroquine 200 mg daily. So after giving of this medication, the surface improved on a course of 3 months, and the drying, this is a picture after the 3 months course. So we planned a left eye cataract surgery after giving 3 doses of IV methylprednisolone on day before surgery, on the day of surgery, and the post of day 1. So ideally in this type of cases, dry eye cases, the eye scan was very difficult to obtain. So we taken K1, K2 an average of 44 diopters, and we have taken the eye scan, which is challenging in this type of cases. And we have performed cataract surgery to the patient. Cornea generally is thinned out at 8 o'clock. So we made a superior temporal incision. The visual clarity is very hazy. Why? Because due to corneal irregularity. And initially their adjunctant flag sign is also noted. So we managed with the Rexis forceps, and we have phaco, we have done phaco emulsification with direct shop method. And most of the time we made the incisions in the normal cornea area. So not in the thinner areas. And the wounds are sutured instead of hydration. Why? Because any hydration can lead to thinning portions of the cornea. And this is the picture where the right eye visual improvement to CF 3 meters and the left eye which the visual improvement to CF 6 meters. Discussion part, we have taken the stepladder approach of Moran's ulcer of immunosuppressants by Virender S. Sangwan sir, and even my mentor has a successful managed of moderate and severe Moran's ulcer at the rural centers in the mainly type 3 centers of in Indian part. One peculiar thing about my case is one eye is with PUK and other eye with dry eye. Aggressive approach with systemic immunosuppression, topical and systemic medication can improve the quality of life and vision. Multidisciplinary approach can improve both quality of life and quality of vision in autoimmune disorders. Thank you.
Right. Thank you, Doctor, for the presentation. May I invite Dr. Lippy Mittal for our comments on this case, please?
Yeah, hi. It was a very nicely presented case. And you rightly mentioned that whenever we are doing a cataract surgery in such cases, we need to give intravenous methylprednisolone cover also. My question is, what IOL did you use in this case?
3-piece IOL we have used, ma'am.
Okay, and what are the complications that you anticipate in such cases?
Mainly the perforation we have suspected, ma'am. Why? Because most of the thinner parts, some are visual clarity, mostly due to corneal irregularity while performing. And the most thinner, the cornea is thinner at 8 o'clock. So we have to perform all the procedures to small superior temporal opening incision. And we have anticipated Argentina flaxen as it is a mature cataract. Mostly, yeah, ma'am.
Also, what was the time or gap between the recovery of the cornea and the cataract surgery?
3 months, ma'am.
Okay.
3 months we have actually we have done primarily for the right eye. Then afterwards we shifted to the left eye after we are identifying the clarity of the cornea surface improved. Where we can see in the previous slide there are some dry filaments on the cornea. When I have shown the older slide, the filaments are disappeared and the cornea is somewhat clear.
Okay, thank you.
Right. Thank you, doctor. So we'll move on to the next presenter. Can you please stop sharing your slides now? So I'd like to invite Dr. Sahila for a next presentation. The
Yes, sir.
presentation is titled Through the Narrow Window, Managing Cataract and Cornea Plana. Over to you. You can start sharing your slides, please.
Is my slides are visible?
Yes, doctor, it's visible. But we're not looking at your slides right now. It's on some other window.
No, you went back. You have to. You have to start your slideshow. Go to the. No, not that. Yeah.
Good evening, one and all. I'll be presenting on Through the Narrow Window, Managing Cataract in Cornea Plana. A 42-year-old male with no known comorbidities hailing from Tamil Nadu presented with complaints of diminution of vision in both eyes since 1 year. History of poor vision since birth followed by gradual worsening of vision in both eyes over 1 year. History of similar complaints in sisters and paternal uncle, no other significant history. This is a pedigree chart showing the affected sister and the paternal uncle. On general examination, patient had short stature and short and stubby fingers. Rest of the general examination was within normal limit. Systemic examination was within normal limit. On ocular examination, both a downward slanting of palpebral fissure was there. Coming to the right eye examination, visual acuity in both eye was hand movement close to face with APR accurate. Sclera conjunctiva was within normal limit. This anterior slit-lamp image of the anterior segment, which is showing horizontally oval cornea with corneal diameter of around 9 cross 8 mm, with ill-defined limbus with absent lucid zone, and there is peripheral corneal opacity, and there is slit-like pupil, which is pupillary phimosis present. Rest of the anterior segment was within normal limit. On dilated examination, there was no view due to poor mydriasis, so we did B-scan. B-scan retina was on, vitreous was anechoic. To delineate the anterior segment structures and to know about the anterior chamber extent, we did ASOCT and UBM, and manual axial length was measured. Right eye it was 28.45 and left eye it was 28.02 mm. And white to white measurement was done. Right eye it was 10.6 mm, left eye it is 14.9 mm. This is a pentagram quad map of the patient showing the curvature map is showing the flat cornea with the K value around 30 in both eye. So my final diagnosis, partial sclerocornea with the cornea plana. So for this patient, we adopted a staged surgical management. First, we proceeded with the left eye sphincterotomy. Surprisingly, intraoperatively, we found rock hard black cataract. So 2 days later, we proceeded with the right eye sphincterotomy plus extracapsular cataract extraction plus posterior chamber IOL. Then patient was discharged after 2 weeks. 1 week, 2 weeks later, patient reviewed and readmitted for left eye cataract surgery. This was the postoperative day 1 of left eye sphincterotomy with visual acuity of hand movement close to face, PR accurate, revealed black cataract. This is a surgical video of right eye, using vitrectomy cutter, we did sphincterotomy. It revealed black cataract. Using endolight, with the help of endolight illumination, we did capsulotomy, and then extra capsular cataract extraction was done through a short scleral tunnel, and a single piece rigid IOL kept in capsular bag. It is a post-op image of right eye with the visual acuity was improved to 660 with PR accurate. And this was the image on discharge. Right eye visual acuity was 624 and left eye was hand movement close to face, the PR accurate. Later, 2 weeks later, patient had undergone left eye similar procedure with a scleral tunnel. Vision improved to 636. So my key points are sclerocornea is a rare inflammatory, non-inflammatory, non-progressive congenital corneal opacity in which cornea acquires scleral characteristics associated with systemic and ocular condition. There are mainly 4 types of sclerocornea: isolated peripheral sclerocornea, sclerocornea with anterior segment alteration, diffuse sclerocornea, and planar cornea. So managing cataract in such eyes carries significant surgical challenges like small pupil, small cornea, shallow anterior chamber, which requires a calculated and multi-step plan to optimize the visual outcome of the patient. In our patient had pupillary phimosis and sclerization of peripheral cornea. Anterior chamber extent has to be estimated through UBM and ASOCT, and the endolumineter was used for capsular management. Thank you.
Thank you, doctor. So do we have Dr. Lala here for her comments on this case? Dr. Lala, are you present here?
I think she is still in OT.
Okay, so I think we'll just hand it over to Dr. Lippy for her comments on the case now.
Yeah, I think cornea plana with slit-like pupil and black cataract, that's a nightmare. But it was a very well-managed case. What IOL formula did you use? How did you calculate the IOL power?
We used Barrett's universal IOL formula, ma'am.
Okay, but do you know the lowest keratometry limit in Barrett? You mentioned the flattest keratometry was 28 diopters.
Yes, ma'am.
Do you know the lowest limit of
I'm
Barrett?
not sure. I'm not sure, ma'am.
It is 30 diopter in Barrett.
Okay.
Okay, all right. So I think corneal IOL calculation is slightly tricky in such cases. We need to use multiple formulae to calculate IOL. But Barrett's, I think the lowest limit is 30 diopter, if I'm not wrong. So I don't know.
Okay, so can we move on now to the next case if you are done? Yeah. So thank you for the presentation, doctor. You can stop sharing your slides now. So we'll move on to the next presenter, which will be Dr. Ayapriya. She is going to be presenting on a case of patch grafting of bilateral ocular surface nevi, a pediatric case report. Dr. Ayapriya, are you present with your slides now?
Yes, sir. For the clarification, I'm Jayapriya, sir.
Okay, it says, in my list it says, sorry about that. Okay, Dr. Jayapriya, you can start your presentation.
Good evening, sir. Good evening, one and all present here. Is my slide visible, sir?
Yes,
Yes,
it's visible. Just go to the presentation. Yeah.
I'll be presenting a case of
Timer,
patch grafting of bilateral ocular surface nevi, a pediatric case report. 10-year-old boy, just a minute. A 10-year-old boy brought by his mother with complaints of fleshy growth in both eyes, which was progressively increasing in size over 3 months. He was previously diagnosed with epidermoid nevus syndrome in 2019 and had underwent excisional biopsy of the limbal dermoid in the right eye, histopathology of which revealed a compound nevus. At present, his examination showed a hyperpigmented lesion extending across the right side of the forehead, root of the nose, and over the right lateral canthid region. Ophthalmic examination. Best corrected visual acuity in his right eye was 2/60, no improvement in glasses and pinhole. Left eye 6/12, no improvement with glasses and pinhole. Right eye, there was a hyperpigmented lesion noted in the lateral aspect of the right eye, along with pigmentation noted in the palpebral and the bulbar conjunctiva and over the cornea, with fleshy growth extending from 5 to 7 o'clock position near the limbus. Of the left eye, there was a single solitary growth noted between 1 and 3 o'clock position near the limbus. The rest of the anterior segment and the fundus was normal. Anterior segment optical coherence tomography of the right eye showed extension of the lesion in the superficial layers in the first and second image. The third image, there was a raised hyperreflectivity lesion suggestive of clinically correlated to the limbal dermoid, and in the left eye there was an elevated hyperreflective lesion seen temporally. The child then underwent limbal dermoid excision of the left eye first with this post-op best corrected visual acuity to be 6-9 parts. 3 months post-op, he underwent lamellar limbal dermoid excision with lamellar patch grafting in the right eye. In the right eye was done with conjunctival resection was done, and this is the post-op picture with the best corrected visual acuity of 3/60. Histopathologic report revealed fibrocollagenous lined focally by stratified squamous epithelium containing adipose tissue suggestive of dermolipoma. Why this case was discussed is because the incidence of limbal dermoid is about 1 to 3 cases per 10,000 individuals. The bilaterality is very rare of almost only 5% of the cases. It can be associated with eyelid colobomas and other staphylomas, choristomas, lacrimal gland irregularity. Of them, nearly 30% would require a lamellar keratoplasty. This lamellar keratoplasty is a skill-dependent surgical management requiring precise surgical techniques, and also for the management, we could this could open up a portal for further research. Thank you. These are my references.
Thank you, Doctor. So, can I have Dr. Mohammed Asif for his comments on this case, please?
Dr. Jayapriya, it's a nice case. A surgical video would have been a good addition because more of focused as a surgical case. So, and the second thing, pre-operatively, a UBM or something would have helped you assess the depth of the lesion, like how deeply it has been penetrated.
Okay, sir.
And I would also want to know, like in the patch graft that you did for the right eye, so the
Yes, sir.
scleral part, so what you did a partial resection of sclera, or like how was
So
that?
this actually we after mounting the button on the artificial anterior chamber using a microkeratome of around 400 micron blade, we actually dissected the superficial lamellar part only, sir, superficial stroma. The sclera is the patient's sclera only, sir. We just sutured it over there, sir.
Okay, great.
Only the corneal button is taken.
All right. Okay. Thank you.
Thank you, sir.
Thank you, Doctor. So, our next presentation is going to be Dr. Renuka. So, she is going to present to us about keratoplasty again. Dr. Renuka, are you present with your slides?
I think Dr. Renuka is not available.
Okay. Can we move on to the next case then, Dr. Ayushi Bansal?
Yes, sir, I'm here. Okay.
Yeah. So, Dr. Ayushi Bansal is going to present to us about Beyond Breath, a Viral Awakening. Over to you, Dr. Ayushi.
Sir, are my slides visible?
Yes, doctor, it is.
Okay. Good evening, all. Myself, Dr. Ayushi, and I'll be presenting a rare case on the topic Beyond Breath, a Viral Awakening. I have no financial conflicts of interest, and consent has been taken from patient to use his photographs for medical purpose. So, a 60-year-old male with COPD exacerbation was admitted in emergency with fever, cough with expectoration, and loose stools. He had a past history of treated pulmonary TB and further started on nebulized budesonide and Dulin for his respiratory distress. Within 24 hours of initiating inhaled steroids, he developed bilateral periocular ulceration, redness, watering, and photophobia, and for this he was referred to ophthalmology department. He had a past ocular history of cataract surgery being done for both his eyes 3 years ago, no past ocular history of any infection or herpetic disease, no steroid eye drop usage history, no trauma history, or no contact lens usage history. On ocular examination, his unaided vision in right eye was 6 by 18, improving to 6 by 9, and in left eye it was 6 by 36, improving to 6 by 18. And extraocular movements were full and free in all the cases. As we can see in this picture, he had severe periocular crusting and ulceration involving both upper and lower eyelids and had conjunctival congestion. On slit lamp examination, we noticed he had corneal epithelial defect, which was typical dendritic pattern and was fluorescent stain positive, and it was markedly central in right eye, then in left eye. And to be noted, as shown in this video, he had marked corneal sensations reduced in right eye, then in left eye. Okay. So on systemic investigations, it was seen that he had raised TLC, raised CRP, and deranged creatinine, indicating a systemic stress and transient immunocompromised state. RBS and viral markers were not significant.
So we ruled out these differentials: Staphylococcus perfritis, zoster pseudodendrites, fungal keratitis, acanthamoeba keratitis, and allergic blepharoconjunctivitis, as all these are not the causes of true dendrites and also marked corneal reduced sensations. So my clinical impression suggests bilateral blepharokeratoconjunctivitis triggered by inhaled corticosteroids. So we managed the case by giving topical acyclovir ointment, lubricant, eye drops, topical antibiotics. Systemic antivirals were avoided in view of deranged KFT, and inhaled steroids were discontinued after discussing with the pulmonary department. So why the viral awakening angle? Even inhaled steroids can cause local or systemic immunosuppression. HSV may first present in steroid exposed or systemic ill patients without any prior herpetic history. Bilateral herpetic keratitis is rare, and early recognition is key to prevent corneal scarring, neurotropic keratitis, or vision loss. So, my take home message from this case is that in COPD patients on inhaled steroids, ocular symptoms must never be ignored. Steroids, whether topical, systemic, or inhaled, can unmask the viral keratitis, and high suspicion and early antiviral therapy saves the sight. These are some of my references. Thank you.
Right. Thank you, Doctor. Could I have Dr. Mohammed Asif once more for his comments on this case, please?
I would like to ask you, like, what is the subsequent outcome of this patient? Like, once you started on topical acyclovir, so did the patient respond, and how long did it take for the patient to
Sir, actually, we lost the follow up this patient. Earlier, also he was like very negligent to start the medications and all. So we though asked him to start the medications, but he was like he was very poor and all that, so he didn't start the medications. So unfortunately, I had not his follow photos, but yeah.
All right. So usually it looked like apart from the dendritic pattern of ulcer, like it also looked like the surface and epithelial breakdown is happening. So in these patients, I would suggest like the patient should not be using topical acyclovir for a longer duration, because they tend to use it for long duration. They end up having neurotrophic ulcer.
Okay, sir.
Okay.
Thank you, sir.
Right. Thank you, Doctor. So we'll now move on to the next case. So the next case will be presented by Dr. Rohini. It's a case of unexpected haze, a case of central toxic keratopathy after Smile Pro. Over to you, Dr. Rohini. You can now start sharing your slides.
Okay, sir. Good evening. Is the slide visible?
Yes, yes, it is. You'll have to speak a little louder though. You're not audible.
Okay. Good evening, all. I'll be presenting a case of central toxic keratopathy after Smile Pro with corneal cross-linkage. A 24-year-old female presented with for refractive surgery consultation, and she was a long-term spectacle user for more than 10 years, with a baseline refraction of minus 4.75 spherical in the right eye, with minus 1.25 cylindrical, and with minus 3.75 spherical and 1.5 cylindrical in the left eye. And the best corrected visual acuity was 6/6 and N6 binocularly. Her anterior segment and frontal examination was normal in both eyes. The central corneal thickness in the right eye was 492 and in the left eye was 491. Given the corneal thickness and the refractive magnitude, Smile Pro with adjunctive corneal collagen cross-linking was advised to optimize biomechanical stability and to reduce the risk of future ectasia. Procedure was uneventful, and on post-operative day 1, her uncorrected visual acuity on the right eye was 6/24 and in the left eye was 6/12, which was improving to 6 with refraction. And on six-lamp examination, we could see a diffuse anterior stromal case in both eyes. And our clinical impression was stage 1 diffuse lamellar keratitis and keratopathy, and we started on steroids. This is a post-operative day 1 picture showing some stromal haze which was diffused. And on the next day, the vision was improving to 6/6 partial with both eyes, and the haze was also improved significantly. And our plan was to continue steroids and to review after 5 days. But the patient presented to the OPD on POD5 with recurrence of the blur and irritation, and the uncorrected visual acuities dropped to 6/12 in the right eye and 6/9 in the left eye. And we could see a central dense stromal phase with early stromal ment and visible interface striae. This is the Sitlam picture where we can see the central stromal phase, and there was thinning. It was confirmed with the ASOCD picture, which shows hyperreflectivity more in the anterior stroma than in the posterior stroma in both eyes. And also topography revealed significant thinning with tangential anterior curvature showing reducing to 29.57, and the stromal thickness was also reduced. This is the left eye picture where the tangential anterior curvature was just 33, and there was a reduction in stromal thickness also. So this clinical picture was consistent with central toxic keratopathy, and the key clues were paradoxical worsening on steroids, hyperopic shift, and the central stromal thinning with striae. So we managed the case with the oral doxycycline, oral vitamin C, and we stopped the steroids immediately. And we put her on preservative-free lubricants and hyperzol, and the close serial follow-up was done. This is the 1 month review. Our uncorrected visual acuity was 6/9 parts in the right eye with 6/9 in the left eye. And there was improvement in tangential anterior curvature to 34 in the right eye. And the thickness of the stroma was also better. In the left eye, it improved nearly to 38. And the current status, which is the follow-up after 2 months, there was a progressive improvement in the symptoms and vision also. Corrected visual acuity now is 6/6 parts and 6/9. Patient was symptomatically better and stromal clarity was also gradually improving. This is the picture of the right eye and left eye, which shows improvement. And the topography also, it was improving to 40. And the take-home points is CTK is a non-inflammatory, non-infectious stromal collagenol and if it's more mismanaged initially as DLP and steroids worsens the CTK. Hyperopic shift is a red flag, and treatment is supportive and aimed at halting the collagen degeneration. Thank you.
Thank you, Dr. Rohini, for the presentation. Can I invite Dr. Lippy for her comments on this case, please?
Yes, it was a well-presented case. So my question is, what do you call it when you combine SMILE with C3R? What is the name of the procedure?
Smile extra.
Yes. Also, why was not a phakic IOL preferred in this case?
Ma'am, since the thickness was only borderline, ma'am, you can always smile and see to prevent the risk of aphasia.
Okay, but in thinner corneas, phakic IOLs are better. Also, visual recovery is faster. Now, you have mentioned that these cases are often misdiagnosed as DLK. So, how do you differentiate CTK from DLK?
DLK, it presents on POD1 and it will be diffuse subepithelial phase, whereas CTK is in the anterior stroma and presents after 3 to 9 days, and the steroid has worsened the symptoms and the findings.
Okay, thank you.
Thank you.
So at this point, I'd like to Doctor.
Hello.
Yeah, maybe.
Okay. Yeah, you can take over now,
Okay,
Doctor.
hi. Thank you. So they've all done such a great job. I'm actually enjoying the session so much. Let's invite the next speaker, and that could be Dr. Angel Smriti Kolo, and she will be talking on when normal isn't safe, normotensive glaucoma, a silent thief of sight. You there?
Yeah, Dr. Angel is there. You can start your screen share. Dr. Angel, can you speak?
Yeah, am I audible? Yes, Angel, you're audible. Don't worry about it. Go ahead. Now we can see your screen. Just switch on the slide share. It's at the bottom right. Yeah, perfect. Go ahead.
Good evening, one and all. My case is when normal isn't safe, normotensive glaucoma is silent thief of sight. I have no financial disclosure. My aim in the study is to assess the systemic risk factors and ocular findings in patients with normal tension glaucoma. And the objectives are to evaluate the demographic profile and the systemic comorbidities in NTG patients and to assess the optic nerve changes and RNFL thickness using OCT and to analyze the visual field defect patterns using automated perimetry. So my method involves cross-sectional hospital-based study in age group of more than 40 years of age over a period of 1 year with IOP of less than 22 mmHg and more than more than one visits. And the patients usually presented to us with other findings, and the patient came to us with incidental findings. And after making the diagnosis, we followed up the patients thereafter. So my inclusion criteria were age more than or equal to 40 years, IOP of less than 21 mmHg. Optic disc changes, visual field defects, and open anterior chamber angles, normal anterior segment, and no media opacity like cataract, and reliable visual field tests. Exclusion criteria involves elevated IOP of more than 21 mmHg and secondary causes of glaucoma and optic neuropathies of non-glaucomatous origin like ischemia and conditions affecting fields or optic disc like diabetic maculopathy, and there should be no history of, and also if there's any history of intraocular surgery previously done. My assessment protocols involved the usual ocular history, asking them about their family history and any drug usage and systemic illness history. The ocular examination, which involves the anterior segment evaluation, and then visual acuity, IOP, especially with diurnal variation and central corneal thickness, because that can actually underestimate or overestimate the IOP, and the gonioscopy, obviously, to check the anterior chamber angles, and optic nerve head and
Fine. Doctor, I think your internet got disrupted.
Yeah, I thought my internet was not working.
Yeah.
Dr. Angel, can you hear us?
Meanwhile, we'll say would invite the Dr.
there
Rolika
are
to introduce yourself.
OCT fundus photography.
Cheers, John.
Yeah, she's
She
on.
needs to
Go
be
ahead.
there. Yeah, Dr. Angel, you can resume.
She's muted herself.
Dr. Angel, can you unmute yourself?
Okay. Very sorry. Am I audible now?
Yes.
Should I continue my?
Okay, we'll give you 1 more minute time. Yeah, we'll stop it. Yeah.
Yep, go on.
So should I repeat the slide or can I move on to the next slide? I just finished the slide assessment protocol. Audible?
You can continue.
Yes, Dr. Angel, we are a bit flexible on the time. You can continue.
So it's not.
Slide's not moving.
Just click inside the slide. Yeah.
Yeah. Okay. And follow-up and monitoring, it involved IOP measurement every 3 to 6 months, and visual fields and OCT done at every 6 to 12 months, and optic disc photography done to compare with the previous visit. And I didn't put up much images on this, but the study which involved that it had female preponderance, and mostly in the age group between 40 to 60 years of age, and systemic involvement was mostly seen in almost more in related with diabetes mellitus, then hypertension, and then migraine. And also a positive history of glaucoma also was noted in those patients. And definitely neuroretinal thinning was also noted in almost 14% of cases, and followed by peripapillary atrophy and also polar notching.
You can take the extra minute, Dr. Angel,
Yeah,
please.
this is my last. So conclusion is in this cohort, it showed female preponderance, common systemic associations, and characteristic structural and functional changes despite normal IOP. And early detection is vital to prevent central loss. So what we can do in these cases, to prevent such cases, is that we can incorporate IOP examinations in routinely for all ophthalmic examinations, because by the time patient presents to us, it's very late, and we can pick up those cases quite early, and so that since it is a progressive and irreversible condition, so that we can pick up and follow up those cases and do our best treatment. Thank you.
Good job, Angel. That was really well presented. Now, can I ask Dr. Arshi for her comments on this?
Hi, Dr. Angel. So you had some technical glitches, but a good presentation. I actually wanted to ask you basically, what do you think was novel in your study?
Normal as in
Novel. What was new?
Novel. Since glaucoma is a very it's a progressive and it's an irreversible loss of nerve fibers, and it cannot be reversed if despite the giving treatment. And by the time patient comes to us with presentation, it can be too late, because most of the time patient does not come to us unless it's very symptomatic. So if we routinely incorporate IOP screening in general for all the patients, then in that case, and plus with with routine fundus examination, especially slam biomicroscopy, because OCT and doing OCT is not feasible in all the setups. So at least retinal biomicroscopy can be done, and then we can pick up those cases, and we can counsel those patients and ask them to come and follow up and explain to them the condition, and so that we can do better for them.
So, as a paradigm, any patient who comes to you with a family history or any predisposing factors, or any patient above the age of 40 to 45, you have to evaluate all of these factors for glaucoma, because normotension glaucoma is something that you will miss otherwise.
Yeah,
As a routine comprehensive examination, and also I think we tend to do our disc and IOPs for most of our patients coming to the OPDs, even the patients coming with itching and watering. So good. Thank you so much.
Thank you so much, Dr. Angel and Dr. Arshi. So let's move on to our next talk. And I see Dr. Nishant S is already ready. And I request Dr. Shweta Shri also to be ready next. Dr. Nishant will be talking on when the cataract cleared, but the vision didn't. Over to you, Dr. Nishant.
Thank you, ma'am. Just a second.
Yeah, take your time.
Okay, so greetings everyone. So today I'll be talking about something which is actually very simple. It's not a wow kind of a diagnosis. It's not something that you have to use your brains or something. Very simple and very simple stuff which can actually go wrong in your day-to-day life as cataract surgeons, because most of us are going to do that for the rest of our lives. So the topic is when the cataract cleared, but the vision didn't. There's no financial disclosure. So we've got a 56-year-old male patient who complained of diminution of vision in both eyes since 6 months and had no comorbidities at all. So when we examined him, his visual acuity in the right eye was 624, pinhole improvement to 618. In the left eye it was 636 with pinhole improvement to 618 parts. His anterior segment was absolutely normal. His lens had a cataract in both eyes, NS2 plus PSC grade of cataract, well dilated case. His posterior segment again was within normal limits, nothing fishy there. So his BCVA, just to check this thing, it was minus 4.5, minus 0.5 at 80. He got 618 vision in the right eye. In the left eye, it was minus 5.5, minus 0.5 to 170. He achieved a 618 parts vision. So the patient was ready for surgery. So we got an A scan done. So this is the A scan of the right eye. he opted for an acryol lens. Again, no financial disclosure from the care group. So we usually take the first negative value, the first myopic value here. So we took a 21.5, which was supposed to have an outcome or leave a residual refraction or a residual power of almost emmetrope in the spherical aspect and around 0.5 in the cylindrical aspect at 122 degrees. So this was the expected outcome of this patient, is refractive outcome. So we implant the lens which was implanted again was 21.5 acryol. So the patient underwent phacosurgery plus PCIOL, topical steroids, antibiotic, NSAID, a midriatic was also added in the post-op medications. Patient came back for day 3 follow-up, and this was the picture. The vision in the right eye was 618, improving to 6.6 with pinhole. The cornea was clear, AC was formed, air bubble was there, PCIOL was in proper thing, and so we didn't have a doubt as to why the 618 was there. We thought, okay, maybe it's day 3, even though the surgery went uneventful, nothing happened. It was 618. We thought maybe because there was air bubble, maybe the midriatic, which was tropicamide that we used, acted in some kind of mechanism that we didn't know. So we just left it there. We didn't actually think about it too much. Patient came after 3 weeks for follow-up, almost 25 days post-op. The visual acuity again was 618 with pinhole improving to 6.6. Now the worry started. Why is it like that? So when we did a BCVA, as in like when we checked his refraction, he got 6.6 vision with plus 1.5 diopters, with his AR reading showing over plus 2 diopters in the positive reading. His anterior segment again was absolutely normal. So the diagnosis that we came was right eye refractive surprise. So after this, we couldn't do much because it already 25 days. We could have explanted, we could have put another IOL, but we didn't do it. The patient also wasn't willing. So from minus 5.5, he came to minus 4.5, he came to a plus 1.5, which was too problematic for him, from myopic to an hypermetropic shift. So we want to dig in. So we dug. So the fundus was checked firstly for macular edema, if there is any. OCT macula was done. A perfect macula was seen. The effective lens position was checked. We have an Argos with us. So here it gives the actual lens position, which is there. So here you can see this thickened part is the PC, and the lens is sitting somewhere here, exactly in the middle of the bag. We also got it confirmed from the technical team of the Argos machine. So they said that the ELP was not the problem. It was sitting perfectly well. So that also didn't go wrong. What could have been done? Like what we were supposed to do at that point was maybe give him glasses and explain what has happened, give him glasses, maybe do a lens exchange. Again, it's a little tough at 25 days, but it is
Dr. Nishant, are you there? Uh, Dr. Nishant? Okay, I guess let me just see if we can connect still.
This time is almost.
Doctor, I'll try calling him, doctor.
Yeah.
Just 1 second. 1 second.
Okay,
Yeah.
sure. Yeah.
Maybe meanwhile
So, anyways, we can proceed with the next talk and take the question on this one after that. Is that okay, Dr. Karthike?
I think its time is almost complete. Yes,
Yeah,
5 minutes more than that.
yeah.
We can invite a judge for the question. I think.
Yeah.
Audible now?
Yeah.
Yeah. Yeah, Nishant, can you just tell us your conclusion, because I think you've already exceeded the time. So just tell us your conclusion and we'll take your questions.
Yeah, the course was that the left eye also he got operated, and the same emmetropic power was put, and he got 6.6 vision. So the take-home message is that things can go wrong, like it can go the other side whenever, even after we do a perfect surgery. So the art of counseling a patient is very important. Thank you.
Okay. Okay. Excellent, Nishant. And may I now request Dr. Balaji to please take the question for this one? Dr. Balaji, can you hear us?
Dr. Akshaya?
Hello. Are you able to hear me? I think
Yeah.
it's frozen. Oh, hi, Dr. Nishant. It was a very well presented case, and it's really a nightmarish case. But I personally feel is an lens exchange at 25 days is still possible. I think
Yes.
that could have been done provided the patient was willing for it. So yes, that is
Thing
why
was the
a
patient
good.
was a little apprehensive about the surgery from first one. So when this happened, he went bonkers as to why this happened to him, and he used to come to the OPD every single day, asking each and every consultant what happened. So we didn't want to go ahead and do that. And again, I mean, who knows? Something else would have occurred or something. So we didn't want to meddle too much, and we kind of consoled him and said that this is the thing, and we gave him. But we couldn't find the reason as to why this happened.
Maybe incision related astigmatism, refractive changes have to be taken into consideration, and also a good pupillary reaction and other things have to be done during preoperative evaluation in almost every case. And as you rightly mentioned, counseling is a very important part pre as well as post surgery, especially after complications, and always a close follow-up helps us in preventing such things and finding out complications at the right time to intervene. Thank you. Well presented case.
Thank you. Thank you, Dr. Akshaya, for the comments. And now, do we have Dr. Shweta Shri with us?
Yes, ma'am.
Okay, perfect. Dr. Shweta Shri, you can proceed with your presentation. And she'll be talking on a sudden twist in a long-standing treatment journey, BAK-induced allergic contact dermatitis. Over to you, Dr. Shweta Shri. And I can request Dr. Suvarna to be ready for the next one. Perfect. We can see your screen.
Good evening. I'll be talking about a sudden twist in a long-standing treatment journey. A 79-year-old male patient came with chief complaints of swelling around both eyes for past 3 months. The swelling was sudden in onset, progressive, and associated with redness around the lids and around both eyes. Patient was treated at a local eye clinic in Palakkad where he was prescribed antibiotics, and he was sent to a dermatologist and was recommended moisturizing ointments and tablet fexofenadine 120 mg for the same. Unresponsive to the treatment, he visited at a hospital at Coimbatore where he was diagnosed as allergic conjunctivitis and treated with chloramphenicol and hydrocortisone eye ointment and cetirizine tablets. Without any significant improvement, 2 weeks later, he visited at a hospital again at Salem where he was treated again as allergic conjunctivitis and was prescribed antihistamine eye drops. A week later, the patient came back with non-resolution of symptoms. There was no history of any exposure to foreign body, no history suggestive of any allergic conditions, no history of any recent change in face creams, lotions, or change in soap or shampoo. Past history, patient is on anti-glaucoma medications, a fixed combination of dorzolamide 2% and timolol 0.5% eye drops for past 4 years. The patient had absolutely no complaints or side effects with the medications and had good compliance with the prescribed regimen. The personal and family history were insignificant. General examination and systemic examination were within normal limits. An ocular examination showed uncorrected visual acuity of 6.9 and best corrected visual acuity of 6.9 in both eyes. The intraocular pressure was within normal limits. His anterior segment examination showed presence of periorbital edema, eczema, and crusting around the lids, and surface over the swelling was erythematous with blackish pigmentation over the skin surface. There were no visible vessels over the swelling or no discharging sinus in both the eyes. The rest of the findings were within normal limits, except that the patient had pseudo-exfoliative material on the pupillary border and there was posterior chamber intraocular lens implanted in both the eyes. Dilated fundus examination showed a cup disc ratio of 0.7 with inferior notching, and rest of the findings were within normal limits. A differential diagnosis of allergic lid edema, syringomas, drug-induced eyelid eczema, and allergic conjunctivitis was made, and the patient was managed initially with topical antihistamines. Later, at a review in our glaucoma clinic at our hospital, a combination of clobetasol, neomycin, and terbinafine eye ointment was started. Without any resolution of symptoms, he was later prescribed a preservative-free dorzolamide 2% and timolol eye drops, which was started in a BD dosage. The diagnosis. So the patient was diagnosed as BAK-induced drug allergy, both eye pseudophakia and pseudoexfoliative glaucoma. After switching to a BAK-free glaucoma medication, his symptoms completely resolved, confirming the diagnosis. So summary, This case, dorzolamide timolol eye drop combination is relatively safer, unlike other anti-glaucoma medications. This patient had only extraocular involvements and no intraocular involvement, which resulted in the delay in the diagnosis. The switch to a BAK-free formulation led to the resolution of symptoms. So this case shows that how drug allergies can appear in the most unexpected ways in a patient who has been using the drug for so many years without any complaints. A discussion. Use of preservatives helps to extend the shelf life of medications, where BAK is the most common preservative which is used in the concentration ranging from 0.04 to 0.02%. It can cause pro-apoptic effects on the conjunctival, epithelial, and corneal cell lines. It is toxic to trabecular meshwork cells. It can cause inflammatory mediators in lens epithelial cells. At a molecular level, it can cause DNA damage, and the detergent properties can affect the lipid layer. So BAK-free formulations can be used. Other preservatives like purite, Sofzia, and Polyquat can also be used. Thank you.
Thank you so much. That was a wonderful presentation. Now, can I request Dr. Mohammad Asif, to please give the comments on this one?
It was a well documented case, and the patient, is there any change in the brand of the anti-glaucoma medications that led to this, or if the patient is using the same brand of, because like sometimes it happens when they change the medications, the same combination can induce blepharoconjunctivitis.
No, so he's been using the same
brand.
combination, same brand for past 4 years.
It's a very good learning for everyone as well, because like what we usually think is like he has been using the same medications, but this type of reaction can happen at any point of the time, even later during the time of the treatment as well. All right. Okay. Thank you.
Just one comment to add, Dr. Shweta. Sorry to interrupt.
Yes,
But
Dr.
we could also check if there is any problem with the installation, if the patient has any tremors, because there's a lot of extraocular spillage that you can see. I'm very glad that you made the diagnosis of the back toxicity, but you could also check the way the patient is instilling the drops. Thank you.
No, that's actually a very good point, actually, because we've seen patients put it incorrectly. Then you can ask them to try to put it right in front of you, and you will see them spilling it all over their face. I agree. So we have our next speaker, Dr. Suvarna. Dr. Suvarna, are you here? Perfect. So she'll be talking on refractive correction beyond limits, TIPCL implantation in a pseudophakic eye with high myopia. Can I request Dr. Shwetashi to please unshare her screen? Dr. Shwetashi?
Manjula ma'am, can you help in closing?
Yeah.
Yeah,
Yes,
thanks.
doctor. Yeah, thank you. Thank you so much. Yes, go on.
Good evening, one and all. My name is Dr. Suvarna. I am from the Eye Foundation Hospital, Vellore. I'll be discussing a very interesting and unique case. The title of the topic is Diffractive Correction Beyond Limits, TIPCL Implantation in a Pseudophakic Eye with High Myopia. A 24-year-old male patient came with the chief complaint of defective vision in both eyes since 20 years. At 4 years of his age, he had trauma for which he developed cataract, and later cataract surgery is done and PCIOL is implanted. Later YAG capsulotomy is also done. Now at 24 years of his age, he is having a high myopia. Now he wants to get rid of his high power glasses. So on ocular examination, it is pseudophakia in right eye and a clear lens in the left eye. On topographic examination, it is within normal limit. Anterior chamber depth is adequate. So one eye is pseudophakia and other eye is clear lens with high myopia. So TIPCL is selected in both the eyes. Power is calculated and the surgery is done. This is the surgery of the right eye. Anterior chamber is maintained and the iridocapsular adhesion is released. The remnant cortical material is aspirated. With the anterior vitrectomy, any adhesions between the capsule and the IOL are released. Capsular phimosis is released. and the IOL is loaded and it is placed in the sulcus and it is rotated into the position. The other eye surgery is done on the following day. Post-op medications are given. On the first post-operative day, we can see an excellent result of 6/6 vision in both the eyes. On slit lamp examination, we can see the in the back placement of IOL and sulcus placed TIPCL with a good distance in between, confirmed by the ASOCT with good vault height. Patient is on regular follow-ups and without any complications. So if we want to correct a refractive error post-cataract surgery, glasses, contact lens and refractive surgery are the option. For the patient who doesn't want glasses, we can go with the refractive surgeries, which can be done on the cornea-based and lens-based. For cornea-based, refractive error should be less. For high power, we can go with the lens-based surgeries. There are two options, that is IOL exchange and piggyback IOLs. IOL exchange is not possible in this patient because of adhesions and capsulotomy opening. Lenses which can be used are Sulcoflex lens, add-on lens, phakic intraocular lens. Phakic intraocular lens is selected in this patient and it has got advantage like it is low cost, high powers can be treated, thinnest IOL and surgery is easy. But we have to be very vigilant about our complications and we in a long-term manner. There are many studies coming up stating the fact that phakic intraocular lenses are very much useful in post-traumatic cataract surgery, even in pediatric phakic eyes and in post-cataract surgery also. So in conclusion, refractive correction beyond limits is achievable even in pseudophakic eyes with high myopia. Careful selection of the patients and surgical precision is the key. For residual powers, for high myopics or hypermetropics, for kertorefractive not suitable patients, we can go with the phakic intraocular lenses, giving satisfaction both to the patient and also to the surgeon. Thank you.
Thank you, Dr. Savarna. May I request Dr. Lippy to please ask the questions?
Hi, Dr. Suvarna. It was a very well presented case. IPCLs or ICLs become very important, especially in these cases where, IOL exchange is slightly riskier. So you did not mention the calculation because of short of time, I suppose. So what are the two parameters that you take into account to calculate ICL or IPCL power?
We have to calculate the power and also the limbus to limbus distance, Y to Y distance for calculation of the size. And also we have to see that the adequate amphibious in the depth is there. If this patient, all these criteria are reached and we have a good adequate chamber and proper calculation is done. So as a result, we could select a good IPCL and replace the lens.
Okay, good. Also, you mentioned toric IPCL. So, do you know any difference in toric IPCL implantation and toric ICL implantation? The difference in placement?
About the openings and
You're not audible.
this
You're
thing
not audible.
which we are talking. Ma'am, are we talking about the hole placement in the lenses, ma'am?
Yeah, the axis placement.
In TIPCLs, it is actually in the leading haptic, the opening will be on the.
No, I think you're not getting the question. So IPCLs are usually placed at 0, 180. There is no rotation. While in ICL, you rotate the IOLs according to the desired axis. So thank you. It was very well presented.
Thank you.
Thank you, Dr. Lippy and Dr. Savarna. Now, can I request Dr. Sanchana Anbalagan to be there? Are you around, Dr. Sanchana?
Yes, ma'am, I'm here.
Okay, perfect. So, and I hope I'm pronouncing your name correctly.
Yes, ma'am.
Okay, sure. All right. So your title would be A Trauma Long Forgotten, A Lens That Remembered.
Yes.
So over to you.
Yeah. Good evening to everybody. I'm Dr. Sanchana from Pondicherry. I'm presenting a topic
Like
of.
to share your screen?
I think I already am.
Your slides are not visible with.
Uh, yeah. Okay. Okay. Good evening to everybody. I'm presenting a topic on a trauma long forgotten, but a lens that remembered. A 33-year-old male presented with complaints of diminution of vision in the left eye for the past 17 years, associated with glare in the same eye for the past 2 months. Patient was apparently normal 17 years back during which he reported a history of hit by a cricket ball 17 years ago, for which he was treated conservatively with medications at a local hospital. There was no history of any ocular surgery. There was no history of any subsequent trauma. There was no history of any recurrent redness, pain, or photophobia, and there was no other significant ocular history. Patient was not a known case of any diabetes, hypertension, tuberculosis, or asthma, and patient was not on any chronic medication. There was no history of any known drug allergies. Patient did not have any history of any exposure to electric shock or radiation. On examination, patient was conscious, oriented, and afebrile. Vitals were very much stable. Head was erect. Facial symmetry was maintained. Eyeball was orthotropic, and extraocular movements were also normal. Right eye was completely normal. The visual acuity was 6/6, and the anterior segment was normal. Fundus was also normal. But when coming to the left eye, it had a visual acuity of 6/24 with pinhole 6/24, with improving with pinhole to 6/18 parts. Lids was normal. Conjunctiva, cornea, anterior chamber, iris, everything was normal. Pupil was 3.5 millimeter, irregular. It was reacting to light. There was no RAPD. But there was posterior synechiae at 5 o'clock position. They always say a picture is worth 1,000 words. So this is how the lens appeared. So the lens showed a rosette-shaped cataract with posterior subcapsular component along with iridolenticular gap inferiorly for about 5 to 7 o'clock clock hours. The intraocular pressure measured by Goldman applanation tonometry was 16 millimeter Hg at 3 p.m. Gonioscopy was done and it was normal. The angles were all open, grade 4 according to modified Schaffers grading. There was no evidence of any angle recession or peripheral anterior synechiae. Fundus examination was also normal. The right eye, the media was clear, the cup disc ratio, blood vessels, macula, foveal reflex, background was normal. Whereas in the left eye, the media was a little bit hazy due to cataract. The cup disc ratio was 0.3:1 with defined disc margins. Blood vessel was normal. Vessels were arising from the center of the disc, branching dichotomously with an AV ratio of 2:3. Macula was normal. One thing to note was the foveal reflex was dull. The background was also normal. We did a B scan on this patient, which showed a clear vitreous cavity. There was no evidence of any retinal detachment, choroidal detachment, or posterior vitreous detachment. Coming to the diagnosis of, leading to the diagnosis of left eye traumatic rosette cataract. So coming to the management and surgical consideration, patient is planned for cataract extraction and synechiolisis with capsular tension rings and with the posterior capsular IOL, or cataract extraction with scleral fixated IOL. In this particular case, we could anticipate capsular or zonular weakness due to the specific iridolenticular gaping. Discussion: blunt ocular trauma may produce a shock wave or a countercoup force transmitted through the lens, leading to disruption of lens fibers and formation of a characteristic rosette or star-shaped posterior subcapsular opacity. As seen in this case, there was a latency of 17 years after which the patient is actually presented. So the latency between trauma and visually significant cataract is months, years, or even decades. Rosette cataracts are a distinctive subtype of cataract, which is more commonly seen in closed cope injury rather than in penetrating injury. Take-home points would be: a late presenting rosette cataract after blunt trauma should trigger the examiner to review any history of trauma. You have to look for subtle signs of trauma like sphincter tear, iridodylisis, any zonules, synechiae, any angle changes, which was not there in this patient. Because such opacities may remain stable for long periods, the decision about timing of surgery may depend upon functional vision, any glare, this patient had glare, quality of vision, and overall ocular health. Documentation and patient counseling is also important because it highlights that trauma may have delayed consequences. So, cataract might not necessarily be age related, but it can be due to secondary to injury. Prognosis is generally good for traumatic cataract as long as the posterior segment is healthy and surgery is timely. I would like to thank YOSI for giving me this opportunity. I'm very happy. Thank you.
Thank you, Dr. Sanjana. And I just request everybody to please try to stick to your time limit. Like, I know that if there's a technical glitch, we'll allow you for the time. But if you go beyond your time limit by 1.5 minutes, it becomes difficult for everyone, right? But it was a very good presentation, Dr. Sanjana. And I request Dr. Akshay to please proceed with the questions.
Hi, Dr. Sanjana. A very well documented case of post-traumatic cataract. I was just curious why you had mentioned how this case was managed later.
Ma'am, unfortunately, this patient had some personal work, work to do. So he did not get operated under us. So he was about to come back to us. And if he does, maybe we would follow some like I already mentioned, we'll perform a cataract surgery on him, and hopefully he gets his proper 6x6 vision back again.
What was the claw cause of Sinike that you had mentioned, and where
Five
you suspect zonular weakness?
5 to 6 was the Sinike, ma'am. And the zonular weakness was about that range too.
Okay. So, what do you think is the indication for surgery in such a case?
Since the other eye had a vision of 6x6, and this left eye had a vision which was lesser than obviously the other eye, we would look for any the patient would obviously start complaining of glare, as already he did in this this patient did. So since on examination we see a very obvious traumatic cataract, and since the patient is also complaining, we can progress and take up the patient for cataract extraction.
So, unless see, this is a case of rosette cataract with a component of posterior subcapsular
Yes.
cataract. So,
Yes.
unless the near vision is compromised, I think that is one of the important points to be considered before taking up for surgery. So, in such a case of trauma, we usually see what is the distant visual acuity, and near area what the patient requires also plays a key role here in deciding upon whether the patient requires surgery.
Yes, ma'am.
Okay, thank you.
Thank you, Dr. Akshaya. And definitely a very cute title, Dr. Sanjana.
Thank you so much, ma'am.
Yeah. And can I invite Dr. Vidushi Dikshit next? And her topic is a case of failing bleb and acetazolamide induced choroidal detachment.
Good
You
evening.
there, Dr. Vidushi?
Good evening, ma'am. Am I audible?
Okay. Yeah. You share your screen.
Yes, ma'am. Is my screen visible?
Yeah, it's just loading. Perfect. And you can just make it full screen.
Yes, ma'am. I'm not able to share my video.
It's at the. No, your screen is visible. Just make it. Just make it full screen at the bottom right.
Yes, ma'am. When is my now it's fine.
Not ready. You see that? Yeah, perfect. Yeah, you're good. Go ahead.
Ma'am, may I start?
Yes, please.
Good evening, everybody. The title of my case is a case of failing bleb and acetazolamide induced choroidal detachment. So, today's case is a case of a 58-year-old male who underwent trabeculectomy. My screen. My screen is not visible to me.
No, it's seen over here. It's all good.
Yeah, for us it looks perfect.
I can't see it.
You know what? You can just escape once, unshare your screen, and then reshare while you are in your slideshow mode. Then it'll be fine.
No, ma'am, I can't see it.
Press escape on your laptop. Are you able to see anything now?
Um,
Yeah, now now you've exited. Now just make sure that you have slide share and then you share your screen. Then it will be visible. Yeah, we are fine now. Are you okay?
No, ma'am, I still can't see it. Just
Okay, while we do that,
now I
can
can see it.
you okay?
Okay, can I just restart?
Yeah, you go ahead and start with this introduction slide. You will find there.
Okay.
Yeah.
So we are presenting a case of a 58-year-old male who underwent trabeculectomy with phacoemulsification and thereby underwent subsequent bleb needling with bilateral choroidal effusion just a day after. Likely attributable cause to this was tablet acetazolamide prescribed to the patient pre and post-op. He was a case of a 58-year-old male hailing from Nagaon, Assam. And he was already a diagnosed case of POAG for 7 years with a family history of glaucoma, a known case of diabetes, already on treatment. On his ocular examination, he had cataract in both his eyes, whereas the IOP recorded for the left eye was 24 millimeters of mercury, measured by Goldman applanation tonometry. And the disc showed advanced cupping with 0.9 CDR with a pale neuroretinal rim. Routine investigations for glaucoma were run for this patient, including a disc photograph which shows advanced cupping in the left eye with HPF, and CCT also were done for the patient, which showed significant changes. He was diagnosed to have a primary open-angle glaucoma with age-related cataract in both eyes and was started on anti-glaucoma agents with monthly follow-up. Despite 2 subsequent monthly follow-ups and stepping up the anti-glaucoma agents, this patient's IOP could not be controlled, and this is when we decided to intervene and go ahead with phacoemulsification and trabeculectomy for the left eye. This procedure went uneventful. However, after 2 weeks, the IOP started showing a rising trend. Despite adding eye drop ripazole, after 4 weeks, the IOP shot up to 28. This is when patient was given tablet acetazolamide to be given twice a day. And patient was advised to undergo bleb needling. We were hoping some amount of IOP relief, IOP control after this, but however, to our horror, the IOP shot up to 40 millimeters of mercury with shallow AC on both sides. On B scan, there was choroidal effusion on both sides. Finally, we suspected acetazolamide to have caused an idiosyncratic reaction, and therefore it was stopped. We started the patient on IV mannitol, gave post and pre, both oral and topical steroids. And after 2 weeks of follow-up, this self-resolved and patient's IOP and visual acuity restored to normal. The important part of this important message here is that we must give acetazolamide judiciously, although it is a routinely prescribed drug. So we have seen similar idiosyncratic reactions earlier in studies as well, and it has to be given judiciously. Thank you.
Thank you so much. Thank you, Vidushi. Now, can I request Dr. Lala to please give her comments? Dr. Lala, do we have you around? Yeah, perfect. Can you unmute yourself, Dr. Lala? Uh, can you unmute yourself, Dr. Lala? We cannot hear you. Okay, I guess Dr. Lala is not able to take the question. Is that right? Okay, perfect. So can I request Dr. Arshi to be around and take the question, please?
Hi, Doctor. Good presentation.
Good
So I
evening.
would want to ask you, do you have any idea whether any role of any topical carbonic anhydrase inhibitor can cause ciliocoroidal effusion?
Ma'am, there are literatures. Actually, I had included that in my slide as well. But due to paucity of time, I skipped due to the glitch. Should I? There
We
have
can
been
go back to it, yes, but mostly it's been with oral acetazolamide rather than
oral
with any
acetazolamide
topical.
is common, not common though, but with topical, not so many reported cases. With oral, it has been reported.
Very rare case actually, that post needling and you had everything and you did not have any component of hypertony that added to it because your pressures were around 40, as you said.
No, ma'am. The
Interesting.
likely attributable cause was a
Choroidal effusion.
ciliary choroidal block. I also read up only after this case that it causes a paradoxical rise in IOP instead of a hypotony.
Coma patients. Also, did you immediately start oral steroids or not?
Yes, ma'am.
All right.
Yes.
No steroid responsiveness in your patient, I hope?
No, ma'am.
All right. Thank you so much.
Thank you, ma'am.
Thank you, Dr. Arshi and Dr. Vidushi. May I request Dr. Pashupaleti Ashok Kumar to please share the screen? Are you with us?
Yeah, hi.
Okay, perfect.
Yeah.
And the topic is going to be disc enigma, pallor or cupping. Over to you.
Good evening, one and all. Myself, Dr. Ashok. Today, our discussion is on disc enigma, query pallor or cupping. So, glaucoma is characterized by chronic progressive optic neuropathy with corresponding visual field changes without rise intraocular pressure. The appearance of the optic nerve head is to suspect or diagnose glaucoma. Typical glaucomatous disc changes will be increased cup disc ratio, violation of Isnett rule with rim thinning or notching, disc hemorrhages, retinal nerve fiber layer defects, visual bionating sign, lamb knot dots, and peripapillary atrophy. This case explores a diagnostic challenge the disc enigma between normal tension glaucoma and post NAIO and optic neuropathy. So, 59-year-old male came with the complaints of defective vision in both eyes since 2 years, which is gradual in onset, painless, progressive in nature, not associated with any color halos or ocular trauma. Not a known case of diabetic hypertensive, acute blood loss, or steroid intake. No family history of unexplained visual loss. General examination, vital signs, and systemic exam with the normal limits. Ocular examination, head posture is normal, no facial asymmetry noted. Eyes are orthophoric. Extraocular movements are full and free in both eyes. Coming to uncorrected visual acuity in right eye, 6/6 blur. Anterior segment is within normal limits of right eye. Intraocular pressure is 14 mm Hg on NCT. And on GAT, it is 14 mm Hg. CCT is 537 micrometers in right eye. Coming to left eye, uncorrected visual acuity is 6/6 blur. Anterior segment is within normal limits. IOP on NCT is 16 mm Hg and on GAT it is 18 mm Hg. CCT is 548 micrometers. Gonio grade for open angles according to Schaffer's grading. Fundus examination, right eye, media is clear. Optic disc is normal in size and shape with well-defined margins. Cup disc ratio 0.8 with inferior notching. Remaining neuroretinal rim is healthy and pink. No pallor is seen. Vessels are normal and foveal reflex is present. Coming to the left eye, media is clear. Optic disc is normal in size, shape with well-defined margins. Cup disc ratio 0.7 with inferior notching. Remaining neuroretinal rim is healthy and pink. No pallor. Vessels are normal. Foveal reflex is present. This is the fundus photo of right eye, and this is the fundus photo of left eye. Phasing of IOP was done, and no diurnal variation is present. This is the single field analysis of 24-2 Sita standard, showing bilateral dense superior field respecting horizontal midline, suggesting a superior altitudinal defect. This is of the right eye, and this is of the left eye. This is the OCT RNFL of right eye on TISNET map showing inferior notching. This is of the left eye showing inferior notching. So coming to summary, a 59-year-old male with a gradual painless loss of vision in both eyes with no comobs, normal intraocular pressure with open angles, and cup disc ratio of 0.8 in right eye and 0.7 in the left eye with no pallor, but visual field showing a superior altitudinal field defect. With this, we came to the conclusion of two diagnoses, probable diagnoses. One is normal tension glaucoma and the other is non-arthritic anterior ischemic optic neuropathy. The points favoring normal tension glaucoma is it is in bilateral, gradual and increased cup disc ratio with no pallor. But against the normal tension glaucoma is central visual field loss is seen, field effect respecting the horizontal midline. Favoring the points of non-arthritic anterior ischemic optic neuropathy is showing superior altitudinal defect. but against it is no parallel cupping is seen, and it is bilateral gradual loss of vision is seen, and no POMOPs are noted. So we have started him on treatment on brimonidine eye drops in view of advanced central visual field defect. We have obtained a neurology opinion. VEP is yet pending. MRI brain is showing normal. So the differentiating features between the NION and NTG is in NTG gradual loss of vision is seen, and cupping is more seen than paler, and arcuate defects and paracentral field loss are seen. In NION, there will be sudden visual loss. Pallor will be greater than cupping, and altitudinal field loss will be seen. So coming to the conclusion, a careful clinical evaluation, especially optic disc and its correlation, are essential to distinguish between glaucomatous from non-glaucomatous optic neuropathies. So attention to history, risk factors, onset, disc morphology, and visual field patterns help to avoid misdiagnosis. So if any pallor is seen, look for the non-glaucomatous causes. Thank you.
Thank you so much. Do we have Dr. Vinod with us yet?
Hi. Hi,
Yeah,
everyone.
hi.
Hi, sir. Hi.
Hi. Can I request you for your questions, please?
Yes.
Yeah.
So it was a nice presentation. So how do you differentiate, as you mentioned, what was the initial narrow down a differential diagnosis, what was running in your mind?
It's NION, sir. Between normal tension glaucoma and NION.
Okay. And what other investigations would you recommend for ruling out both the conditions?
We need to rule out this. We need to send ESR, C-reactive protein, lipid profile.
Okay.
To rule out this NION, sir.
Yeah, fine. And what was the patient's blood profile? This patient's blood profile?
Everything normal, sir. ESR is normal, lipid profile is normal, sir.
Yeah. Okay. Fine. Fine.
Yeah.
Thank you. That was a good presentation.
Thank you, sir. Thank you so much.
Thank you, Dr. Vinod and Dr. Prakriti. Now, can I request Dr. Suvarna Chaji to please share her second presentation with us? And that would be I am not a statue. Extreme ocular surface keratinization in bilateral cicatricial pemphigoid, a clinical challenge. Over to you.
Good evening, one and all. I'm Dr. Suvarna from the Foundation Hospital, Vellore.
Volume a little bit.
The title of my topic is I am not a statue, extreme rare case of end-stage ocular cicatricial pemphigoid. A 50-year-old female came with the chief complaint of diminution of vision in both the
Dr.
eyes since 10
Suvarna,
years.
just 1 second. Can we reset the timer for Dr. Suvarna, please? Just 1 second.
Please.
The timer is still the old timer.
Okay, maybe I'll keep a note on my phone.
Okay,
Yeah.
sure. All right. Go ahead, Dr. Suvarna.
50-year-old female came with the chief complaint of diminution of vision in both the eyes since 10 years. So she is a known case of systemic cicatricial pemphigoid since 20 years. Since 10 years, ocular cicatricial pemphigoid. Initially, it started as conjunctival congestion, but gradually it increased to surface keratinization. Vision progressively worsened. Systemic medication showed partial control. And she stopped the treatment 5 years before because she became non-responsive. On a general examination, she is a very frail, thin, poorly nourished woman with oral mucosal and skin shows heel scars. On ocular examination, her visual acuity is only PL positive. Lid margins are keratinized, conjunctiva is keratinized, cornea is keratinized, fornices are totally obliterated. There is no tear film, anterior chamber is not visible, and fundus is not visible. So now the plan of action is only ocular surface reconstruction or regular systemic follow-up to see for any recurrences. Ocular cicatricial pemphigoid is a chronic autoimmune disorder causing conjunctival scarring. Pathophysiology of which is basically it is a hypersensitivity to reaction where the immune system attacks the basement membrane antigens leading to chronic inflammation and subepithelial fibrosis. Based on the progression of the disease, it is divided into different stages, from the conjunctival injection, next conjunctival scarring, then symblepharon formation, and finally corneal keratinization and cirrhosis. The gold standard for confirmation is a conjunctival biopsy and direct immunofluorescence revealing linear depositions of IgG, IgA, C3 along the basement membrane. Medical treatment is balancing between the immunosuppressive agents and the corticosteroids. The immunosuppressive therapy goes in a step-by-step manner. For the mild disease, Dapsone. For moderate diseases, mycophenolate mofetil, methotrexate or azathioprine. For severe disease, it is cyclophosphamide. For very severe resistant and refractory cases, we can go with the newer drugs like intravenous immunoglobulins, anti-TNF factors or rituximab. Surgical management depends upon the organ that is involved, like for eyelids, punctal occlusion, marginal eyelid rotation; for conjunctiva, autologous graft or limbal stem cell cell transplantation; for cornea, penetrating keratoplasty or keratoprosthesis. So visual rehabilitation is by contact lens, lubricants, and low vision aids. Long-term monitoring is needed for early detection of complications and early intervention of recurrences. Future direction is towards biologic therapies, that is mainly anti-TNF factor, anti-CD20 factors, and T-cell modulators. So the key points and the lessons learned from this case are: early diagnosis is critical in preventing irreversible ocular damage. Tailored and early treatment using appropriate immunosuppressive is important for long-term outcome. Multidisciplinary management ensures comprehensive care and better control of disease activity. Thank you.
Thank you so much, Savanna. May just a second, hold on. Yeah, may I request Dr. Lippy to please take the question? Oh, sorry, Dr. Mohammed, sorry.
Yeah.
Dr. Lippy will ask you also. But I'll have to ask Dr. Mohammed for this one.
All right. Okay. Doctor, it was a nice presentation. So, what was done for your patient? Did you go ahead with OOKP or?
Nothing. Actually, she's very reluctant for treatment because she stopped her overall treatment since 5 years. Now, nothing, sir. Actually, we suggested for ocular surface reconstruction. Because since she is taking medication for a long time, she is now totally reluctant for any treatment.
Okay. So I think the most important thing is like prevention is better than cure. I think this is very apt for this disease because many cases of cases which are presenting just as conjunctivitis many times are neglected, and it tends to ends up having a chronic cicatrizing conjunctivitis. So, and still, even at that stage, it is like important to manage properly. So, with an immunosuppression and other systemic therapies, this case, we can prevent the case from having this kind of an end stage, fully keratinized surface, because pretty much they will not have much options to be done at this point of time other than like keratoprosthesis. So I think all of us here, I think we should, any case of cicatrizing conjunctivitis, OCP should be there, and especially in an elderly patient. And we also have to rule out other cause of cicatrizing conjunctivitis like adenoviral and trachoma and other things. And always topical medications are not much useful in these cases. OCP, it needs a systemic management, and also we need to have a multidisciplinary discipline, like you have to have an referral with the rheumatologist and other things, and start an systemic immunosuppression as early as possible. And I think Dapsone we don't use much these days because of the hemolytic anemia that it causes. I think even for mild to moderate cases, we start with mycophenolate, which is a very good drug. And for severe cases, definitely a cyclophosphamide should be done. Yeah. Thank you.
Thank you so much for such wonderful points. And now can I invite Dr. Angel for the showstopper presentation? Should I call it that, Dr. Angel? Right? The last one, but not the least, of course. So let's have you for facing the reality of modern epidemic, childhood myopia beyond the blur. Are you here, Dr. Angel? Share your screen. And this will be the last presentation, so I think I'll request Dr. Prasanna to be there.
Yes, welcome.
Right. Okay. Yes, Dr. Angel, just click on, yeah, perfect. Go ahead.
Good evening all. My topic is on facing the reality of modern epidemic childhood myopia beyond the blur. I have no conflict of interest. This is a retrospective study using hospital-based data conducted over 3 years after initiating treatment and monitoring the progression of myopia with baseline of from minus 0.25 diopter to minus 6 diopter to assess the effectiveness of low-dose atropine of 0.01% and 0.05% was a spectacle correction alone in controlling myopia progression and axial length elongation in children aged from 5 to 15 years of age. So my concerns were to choose this topic was because of the rapidly increasing prevalence seen nowadays, and also according to WHO and IMI, which recognizes myopia as a growing epidemic globally by 50% and approximately 10% to be reached by 2020. 10% will be having high myopia, and also because of the environmental factors and lifestyle like increased screen time, near work, reduced outdoor activity, and sight-threatening long-term complication in high and pathological forms like retinal detachment, myopic maculopathy, and which leads to irreversible vision loss, and also highlighting the influence of modifiable risk factors. So these are my criteria: inclusion and exclusion. Inclusion include age from 5 to 15 years of age and baseline from minus 0.25 diopters to minus 6 diopters. Type of myopia have included only simple or axial myopia. Visual acuity should be equal, more than or equal to 6/24, and normal anterior and posterior segment pathologies. And apart from this, all the exclusion criteria: age less than 5 and more than 15 years, and pathological myopia, previous ocular history, medical history, any systemic diseases for which the patient is taking treatment, any ocular disease or visual acuity poor, that is less than 6/24. So my assessment protocol is initial evaluation. Again, the detailed history, anterior posterior segment evaluation, the visual acuity and cycloplegic diffraction, orthoptics evaluation to rule out any amblyopia, strabismus, axial length, corneal topography, and intervention to be given accordingly, like spectacles or atropine eye drops, and also counsel regarding the life modifications. And during follow-up, during each visit, we see the visual acuity in anterior segment in each visit, and posterior segment, depending on the frequency, every 6 months, or 12 months, cycloplegic refraction every 6 months, axial length progression 6 to 12 months, and compliance to the intervention we are giving, and any side effects, if any. So pathophysiology-based interventions, what we do nowadays is we promote peripheral myopic defocus, which has a special type of lens, because we have noticed that because like centrally the central vision we are able to focus the image on the retina, but peripherally because it wants to focus the image on the retina, it elongates. So we have to promote peripheral myopic defocus, but this is very expensive because these types of lenses are very expensive. And apart from that, we can also use low dose atropine, which is a non-atropine eye drops, which is non-selective muscarinic receptor antagonist, which acts via the accommodative pathways and retinal or scleral muscarinic receptors, and dopamine release modulation or nitric oxide signaling. So these are my data analysis. So my group, we had 3 groups. The first group had spectacles, which had 90 patients, and group B1, which had which we used atropine with 0.01%, and group B2, which we used 0.05%. And my results came out to be that out of 226 children enrolled, 32 patients were lost to follow. But out of 194, I could find that with 0.05% of atropine eye drops. It had better control in preventing axis elongation. And while it was followed by spectacle group and then followed, and it was highest in the 0.01 group. And side effects were not noted in either of the groups. So conclusion is that the axial and guided treatment effectively identifies children needing pharmacologic intervention, and atropine eye drops 0.05% significantly outperform 0.01% in reducing both myopia progression and axial elongation. Thank you.
Thank you so much, Dr. Angel. And now may I request Dr. Prasanna to please take over. Don't worry, Dr. Angel, we've already taken your questions earlier. You've done a good job earlier. Now we will just move on to Dr. Prasanna's statement. Go ahead.
Thank you
Over to you.
for helping out with the last leg of Naadi. Really appreciate it. And thank you, Dr. Angel. Can you stop sharing your screen, Dr. Angel?
Yes.
Yes, so that brings us to the close of the magnum opus 3-day event of Naadi. So we are going to start the valedictory event in another couple of minutes. Before that, we wanted to acknowledge the day 3 participants, faculty, judges, and presenters. So we have this customary certificate distribution. And thank you, Arshi, for being here as a judge for day 3, as we are getting the results compiled for the last leg of Naadi 3.0. Thank you, Arshi, for being there for 3.5, 4 hours, patiently judging along with Dr. Akshaya Balaji. Thank you, Dr. Akshaya Balaji.
Thank you, sir. We really loved being here.
Thank you, Arshi. Thank you, Dr. Akshaya. Thank you, Dr. Mohammed Ibrahim Asif. We are disturbing you from season 1, and last 3 years you are tolerating with us. Thank you for that. And
Thank you, Dr. Prasanna. It is a pleasure.
Thank you, Dr. Akshaya Balaji and Asif as well. And Niranjan, thank you, Niranjan. Of course, you are part of the organizing team, but he kickstarted the day, and Dr. Aditya Varman moderated the middle half, and Dr. Rolika chipped in as MS Dhoni for the day today, and 3 moderators who helped me, Pranesh, and Karthikeyan to make sure that we get things in order for the valedictory ceremony. And thank you, Dr. Lala, for operating in between and coming and answering. And again, going back to operating, I think really hats off to you for being here despite your tight schedule. We really appreciate your commitment. Thank you, Dr. Vinod Tarunachalam, sir, for always being there for us, even on short notice. Thank you, sir.
Thank you, Prasanna.
Thank you, sir. Thank you, Dr. Lippi, again for sharing your valuable expertise and adding more scientific value to the discussion.
Thank you, sir. Thank you so much.
And again, we are going to quickly read out our international participants of the day. We had started the day with Dr. Somir from Bangladesh. Then we moved to Cambodia by Dr. Han. Then we had Dr. George from Egypt. And we had Dr. Rizga from Indonesia. And we had Dr. Emmanuel from Mexico. Thank you, each and every one. Dr. Berna from Philippines. I think this is just for this day. So we had 6 to 7 international participants on each day for a complete 360-degree coverage, as my favorite Mohan Rajan sir used to say. So we wanted to make sure Naadi covers the globe 360 degrees. And Dr. Bahubali from India, who started the Indian contingent proceedings, Dr. Priyanka, Dr. Siddharth Tyagi, Dr. Snehita, Dr. Apurva, and call upon Dr. Pranesh to continue the Indian contingent distribution. Dr. Pranesh.
Yes, yeah, I'll go ahead. Thank you, Prashna, for the kind shift over. Dr. Meher for AGV-related complication case. Dr. Anko Biswa for Alport syndrome. Dr. Ankam for unpatient rheumatoid. Sahila for cornea plana. Jayapriya for patch crafting in EY. Aishi for viral awakening. Dr. Rohini for Smile Pro case. Dr. Angel for non-intensive glaucoma case. Dr. Nishant for cataract cleared, Dr. Shweta Shri for bark induced, Varna for refractive beyond limits, Dr. Sanchana for trauma long forgotten, Vidushi for failing blood, Dr. Possibility for dysenigma, Dr. Suvarna again for ocular surface keratinization, and that's it. Yeah. Heartiest congratulations to all the participants.
Yeah, thank you. So that brings us to a quick close of day three's short closure, but we start the event quickly with the valedictory ceremony. We welcome two stalwarts in ophthalmology who has been pillars of, especially for people who are coming from this part of the country. We have seen them, we have got inspired from them. And those are reasons why, at least, if not me, many people have taken ophthalmology because of them. So we welcome Dr. Mohan Rajan sir. The AO is Vice President, the All India Ophthalmic Society, and Dr. Sujata Mohan ma'am, the President of TNOA. A quick few words from both of you, ma'am. We'll call you for guest address as well, but quick greetings from you both, and we start the valedictory ceremony. You're not audible, ma'am.
Hello, Dr. Ramesh.
Yeah.
I'll let Sujata go first.
Sorry, who should go first?
Yeah, Dr. Eka, just be on mute. I'll be calling out to you.
Okay,
We're just going to start. Yeah, thank you. Thank you, Dr. Eka. Sujata ma'am, you're on mute, ma'am. We are not.
She's there on the line.
Sir, are you able to hear, sir? I'm not.
No, madam, ma'am has not
I'm able to
connected the audio.
hear.
Sir, Mohan Rajan sir, a quick few words from you, sir, before we start the valedictory event. Karthi, உங்களுக்கு கேக்குதா?
Yeah, it's audible. Madam has not connected to audio, I think. Mohan sir, internet is also a little unstable.
Okay.
I think we can start and welcome everyone.
Valedictory, okay.
Welcome sir, welcome madam, and welcome Sonal ma'am, and welcome Nilesh sir, welcome Devakar sir, welcome everyone sir.
Yeah. Before we start, I think Sonal ma'am, a few words from you, because it was under your presidency that we initiated this novel activity, which has now grown internationally. A few words informally from you before we kickstart proceedings with the valedictory ceremony.
Congratulations to Dr. Prasanna, Dr. Karthikeyan, Dr. Pranesh, all three of you in the very first edition. You brought forward the idea. I tried my best to support you. It was at that time that this was merely a sapling, and now it has grown into a big oak tree, as I can see it, with so many, international participants doing their best, and so many stalwart people also joining in now. When in the very first edition, things were at a really slow and steady, stage, and that was the time that the real learning took place, so that this, like a foundation, it was there, and today it has bore fruit in a way, and I hope that this keeps growing and it stays as one of the events to look forward to for the YOSI team and the young ophthalmologists in general. Congratulations, Dr. Prasanna and team.
Thank you, ma'am. Sujata ma'am.
Are you able to hear
now
me?
you're audible, ma'am. Yes, ma'am. A quick few words from you before we start the valedictory.
Okay, right. So it's a very, I just went through the previous programs. It's a really very interesting concept, and I'm sure that, YOSI, it comes up with so many different things. And it's amazing that so many people have been given an opportunity, and that too across the globe. Prasanna had put up the number of countries which had participated, about 15 of them. And this is a wonderful concept because it's not only gives them an exposure, but also sort of ties you all together. So the world has become like a global village. And the advantage of this is perhaps more importantly that from different places, the thinking is the same. And whatever we are doing is across borders, and ultimately is to help the patient. This is a really wonderful concept, and really appreciate whoever started it and thought of it. I don't know how many of you know the meaning of this Naadi. Has someone explained it to you?
Ma'am, you'll be the right person to kickstart it, and we'll take it over from there.
Okay, so here I have put it: diagnose illness, trace its cause, and seek the proper remedy and apply it with skill. And this is from one of the Jain philosophers who has written 1,330 verses in a text called Tirukural in Tamil. And they are very short and succinct, but they give so much of meaning. And it's really wonderful that Prasanna and the group is friends have adopted this as a title. And as you see, that each and every presentation speaks for the wonderful work being done across the globe, and also the the need for the young skill to come up instead of all of us taking the stage over and over again. This is a wonderful concept, Prasanna, Vinod, and all the others. Congratulations to all of you. And I request Dr. Mohan Rajan to say a few words.
Mohan Rajan, sir.
Shall I go ahead?
Over to you, sir.
Thank you very much. It's always a pleasure. And whenever YOSI calls me, I'm there. I will leave all other work and be there for YOSI. For the simple reason that YOSI is right inside my heart. Okay, it's all dil se. And the reason why I'm telling this is, if you see all the organizations in our associations in our country, whether it's BRSI or the United Society of India or the IRSI, or for that matter, the Women Ophthalmic Society, the most vibrant society will be the YOSI, the Young Ophthalmologist Society of India. The reason why, because I think all of you are very, very young, very focused, very motivated, and very determined and very hardworking as well. And this I found because Prasanna knows. Are you able to hear me, Prasanna, and all other people? Sonal,
Loud
you
and
able to
clear,
hear me?
sir. Loud and clear, sir.
Huh?
Yes,
Loud
sir.
and clear. Okay.
Yes, sir.
And the reason why I was talking about is the YOSI is such a focused unit, and I'm very happy to be associated with the YOSI. And I have to thank the YOSI for solidly supporting me to become the Vice President of the All India Ophthalmological Society today. And we had a fantastic surgical strike last year, and out of which 15 YOSI surgeons, for the first time ever, they operated, did live surgery. Unfortunately, this year we don't have live surgery because of the Supreme Court ruling, but we are going to have YOSI people again on January 3rd and 4th for the surgical strike for the deferred live surgeries. And I was going through this program called Naadi. This is a season 3. I don't know, somehow I missed the season 1 and season 2, but it is simply amazing. It's seriously amazing to see such a wide range of topics to be covered, and so many people from all over the country, the students, the fellows, and all the Young Ophthalmological Society of India have all participated in this. And every topic, as Prasanna was rightly telling, every topic and every aspect of ophthalmology has been covered. So it's essentially it's a 360-degree coverage, which is again very important for all of us. And what I am very, very happy as a vice president of IAOS to note is that our future in the hands of YOSI is very, very good and very safe and very bright, because these are the people who are going to lead the AOS and all other organizations in the future as well. And for the next maybe 10 years or 20 years or so, these are the people we have to watch, we have to groom, we have to encourage to become better and better. We have to take a back seat, and that's what we are trying to do, and give them the opportunity to flourish and become better, and so that they can also be as successful as we are. So this sort of open-mindedness should be there, and that's the reason why I think we AO is also working on this particular principle. And I'm very happy to note that so many participants. How many participants have been there,
Sir,
Prasanna, this time?
95 participants, sir. All around the globe.
95. 95 participants.
Yes, sir, for
So
3 days.
95 participants, each of them giving some case presentation. It is something which is incredible achievement, I would say.
Close to
And
150 came together, sir, with the judges being around 6 per
Yes.
and more than 150 people came together from YOSI for
Yeah,
this.
yeah, yeah. I know, Sonal, I think you are the one who started the whole program, I
Yes,
suppose.
sir. Madam,
Yes.
our presidential
You
term.
started. Really, hats off to you, Sonal, for thinking of this wonderful concept. This concept is something which is very unique, I would say. It is not there in any other organization. And we have to give credit to you for that, for
No, sir, the
bringing
credit goes
about.
totally to Prasanna and Pranesh and Karthikeyan for the name.
No, no, I think it's
For me,
teamwork.
so for me
Yeah.
personally, it was a very milestone event, the season one, because by that time we did not have very South-centric events happening. So
Yes.
that was the day I realized that now YOSI is moving fast and spreading to the whole country very fast. And I hope that Prasanna in the future is able to organize one of the YOSI cons in Bangalore or Chennai or somewhere. And I hope to also come and attend that.
Yeah,
That
yeah.
is something that I'm really looking forward to.
Yeah, what you say is absolutely right, Sonal, because when the OC started, it was all Delhi centric and it was North India centric. And now it has become pan India. And everywhere, every conference, even a couple of days back, last week, I was in UP State Conference, and many UC people were in Gorakhpur, and many UC people were completely taking care of the whole event and participating very actively. And whenever these OC people concentrate, do something, they do it with not 100%, 200% effort and focus, and something which I like
Enthusiasm.
uniformly about all the OC people. So, really hats off to you, Prasanna, and the team, Pranesh and Karthikeyan, all from Tamil Nadu. I'm very proud of them and very proud Singh and Sonal. Of course, President Divekant and Karan Bhatia, I just met him a few days back in Gorakhpur, and all other people like Nilesh and all the other office bearers of the OC who had taken OC to a greater height. But please don't stop here. Okay, very important. Don't stop here. You should have the fire in the belly. You have the fire in the belly. You have to go to greater heights. In my opinion, you should set the what you call the trend for the OC con or the what do you call the international OC. So India should be the base for the all the because I found that even the OCCon and Delhi conference a couple of months back, we had a lot of foreign faculty coming from all over the world, from South Africa, Central Africa, from Egypt, and from UAE, and so many other countries. They came and participated. It was very happy to see. And you are the what do you call you are, I think the OC of India, the Young Ophthalmology Society of India, is the main what you call platform or the base for the all other OCs to come. And you should be the front runner. You should be the game changer. You are already the game changer as far as the international scenario is concerned. You have done very well in India, but don't stop here. You have to go further. And as I told you in YOSICON conference in Delhi as well, that AOS will fully back you up. The AOS will fully back you up for whatever initiatives you are taking. The AOS will fully back you up because we see the need for young ophthalmologists to thrive, to come forward and have a platform for which they can express their sentiments, they express their work, and so many other things they can do on this platform. So once again, I thank Karthik and Prasanna for this wonderful opportunity and wish you all the very best. May God bless you all and may the OC tribe increase.
Thank you. Thank you,
Thank
sir.
you.
We have a small PowerPoint presentation as we are compiling the results as we speak. So as Madam rightly told, so this name was actually coined by Dr. Karthikeyan Mahalingam, and during the presidentship of Dr. Sonal Kalia ma'am, Karthikeyan Mahalingam brought together three of us and he coined this name, Naadi. And as ma'am beautifully explained it in great detail. And in session one, 3 years back, we did season one, and we never expected it to flourish the way it was. And most of the judges are still people who we go to disturb, and they are still part of the Noinadi Team YOSI clan. And so at that time, Dr. Nirmal Frederick sir was one of the guest of honors who acknowledged and motivated this young team under Dr. Sonal Kalia ma'am, under this initiative where we had a preliminary session and a finale, which was again judged by our current Secretary Nilesh and Aditya Treasurer, then Treasurer Dr. Avinish, who all helped us in judging the finale. And we four of us were brought together by Dr. Karthikeyan with like-minded goals. So we had a viewership of 550 plus for the prelims, and we had a finale again well attended with Dr. Nirmal sir motivating the young ophthalmologist around two years, 10 months back. We had it in the first half of 2023. And we didn't stop there. And after the new team took over by Dr. Devakant Mishra sir last year, and again we wanted to have the season 2. And this time we went ahead with the anterior segment, miscellaneous and vitreoretina. And still we had, compared to this, we had a submission of 30 to 40 lukewarm submissions compared to this. But it was evolving from the first year, which Sonal ma'am showed us the way. And Devakant sir and the new team, which was part of with the dynamic executives, we were to navigate even more higher with prelims again well attended, well discussed. And then we had the finale supported by the GSI President of India, Dr. Satyen Parthasarathi sir, again my mentor. And again, senior professors like Vasanta ma'am, Hemanandini ma'am, and Malarvili ma'am. And we had a well supported event, and top 10 and top 12 people were judged, awarded at the International YOSI-Con, which happened, concluded this year. So these were some of the viewerships of second season. And this year, as our president and the new team, which always says going global is the way forward, as MR sir also rightly put on record. So our team also was enlarging. We had Dr. Aditya and Dr. Samir, and well supported by our president and secretary Devakant Mishra sir and Nilesh Kumar. And we were able to expand the horizons internationally. So we were skeptical how it is going to go, but we were well supported by our international colleagues. And we had 15 plus countries, and the viewership speaks for itself as we speak. And some of our colleagues are here. And we designed not a flyer, but a program book for an event. First of its kind for a virtual webinar, a 13-page program book for the international online Noinadi case presentation, where India, being YOSI organizing it, we were lucky to have Vietnam, Sri Lanka, Philippines, Pakistan, Nepal, Mongolia, Mexico. We had people from Mexico despite the time zones, Azerbaijan, Bangladesh, Cambodia, Egypt, Indonesia, Malaysia, and Maldives. We will be soon hearing from their leaders as well, a few words who supported YOSI India. And it is not just young ophthalmologists. It was focused mainly on residents and fellow neophytes who have just started their practice. And 95 plus submissions. Again, a sincere thanks to Devakant sir, Sonal ma'am, Karan, Nilesh, Aditya, and the whole Noinadi team, which each executive member took it upon themselves to have different roles, be it from A to Z, Aditya to Zain. Each one of them motivated their residents. Some were judges like Arshi and Ashish, like Ayushi Agarwal motivated 8 to 9 of our residents. And we had so many ex-executives like Gunjan being part of it, Lipi again being part of the panel, and many, many more who really, like Rolika helped us in moderating today, and Sunandini, Zain, each one of us took part. And the presidential working group, again, this is a dynamic team which again helped us in getting more submissions from Digvijay sir, who's always been a torchbearer to and the other people at all here. And we had Neomedics to support and sponsor this event. This year we went with a industry partner as well. And as you can see, this was a program book which we had with the judges, panelists, and moderators, with the 13-page event, with all the presenters, with the countries, and the residents felt motivated. And many of the feedback that we got was this is one of their first presentations, and we were able to do it on an international scale from anterior segment to posterior segment. As Mohan Rajan sir, one of the reason I took ophthalmology, used to say 360-degree coverage. Sir, I learned it from the 360-degree coverage. Of course, you use it for surgical strike. With your permission, I'm using that here for Naadi. A complete 360-degree coverage of 3 days of extravaganza, and everything starting from the orbit to the retina or beyond the retina, we made sure we had. And here we are with the current chief guests, Madam President of TNOA, Mohan Rajan sir, Vice President AAOS, and all the guests of honor being our in-house people of YOSI, who needs no introduction. Again, Digvijay sir, a past president of YOSI, Sonal Kalia ma'am, I'm immediate past president of YOSI, Devakant sir, again, one of the reasons why we thought Shift International is a seed sown again by our dynamic president, Dr. Karan Bhatia, our vice president, again, Dr. Nilesh Kumar, who we constantly keep disturbing despite the time zones 24/7. We keep torturing him with WhatsApp messages, mails, and whatnot. And Dr. Aditya Sethi for money. And again, myself being part of the team, and Dr. Avinish, our past treasurer, who really guided us. And we also want to place on record the acknowledgements and many people who have also joined despite time zones. It's 8:30 here, it's 11 and 11 plus in many countries, and in Mexico, I don't even know what's the time now. Dr. Lala from Azerbaijan, who has really been a real support and pillar. Dr. Ashraful Haq from Bangladesh and this team. Again, these are people who we continuously phone called, and we disturb them despite day and night, and they have patiently not blocked me, and I hope they'll not block me also after Naadi. Dr. Loam from Cambodia, we have it in alphabetical order. Dr. Pasant from Egypt, again, who has been very instrumental in getting it in Egypt. Dr. Alia and Dr. Vidya from Indonesia, Dr. Vidya and Wei from Malaysia, and Dr. Azam from Maldives, who was here in Trichy yesterday, and is currently still in India, and Dr. Sara Yusuf as well from Mexico. And we had Dr. Franco from Mexico, in Mongolia, Undama, Zula, and the new team that has taken over in Mexico. From Nepal, we have Dr. Amit and team. From Pakistan, we had Dr. Ani Pasha and his team. In Philippines, we had Che, Erika, and their team helping us. Saminda from Sri Lanka and his team. And Vietnam, we had Enga and Hein. So with that, I would really open up the forum before we announce the results. MR sir and Sujata ma'am, again, if you want to add a few more words, otherwise we would like to open it up to our YOSI office bearers and our international YO leaders who are still here with us to share a few words before we announce the results of this 3-day magnum opus 9.5-hour event of International Naadi. Yeah, Sujata ma'am.
Thank you, Prasanna sir. I think Devakant sir has joined us.
You can start with Devakant sir and take it on from there, Narendra.
Okay, sir.
Hi, good evening. So I was just listening to Mohan
Good
Rajan
evening,
sir,
sir.
and sir, good evening.
Good evening.
Ma'am, good evening. So I was just listening to sir, and I just echo all what he has said. And apart from, I'll come to Naadi later. This is one thing that the support that we get from our seniors. I think all the international colleagues who are present today will acknowledge this also, that the amount of support that we get from our leaders is unparalleled. The growth that we have made, the whatever achievements we have had, it is of course because the team effort of the young ophthalmologists, but it could not have been anything without the support from our seniors. So we are very thankful to them, especially Mohan Rajan sir. He said that we supported him for his candidature. It's the other way around. He is the one who has supported us. So it becomes our duty to support whatever he does. So thank you so much, sir and ma'am, for
Thank you. Thank
the,
you.
the wonderful opportunities that you keep giving us. And I'm glad that our team, stands up to the occasion every time. So I'm very proud of the Naadi team, all superstars, the way they have worked. I mean, it's like a marathon. Last few episodes, I mean, last few seasons, we could see the way they have worked, and again they have proved themselves. And now it has become like a mini YOSI online conference. So, I think it's a brand now. Congratulations to the team, and thank you all the participants, our international and national colleagues who have participated. And it's so heartening to see that youngsters, fellows, residents have come up and participated. And it's all because of the Naadi team. So thank you guys. Keep up the good work. All of us are very proud of you. Thank you so much.
Thank you, Devakant sir.
Thank you, Devakant.
Our past president Digvijay sir joined us. Sir, a few words from you, please.
Yes, indeed. I think I completely echo Devakant's words. An absolutely fantastic event overall, and thanks to all the seniors who've joined in, and all of you, the Naadi team as a whole, who has done very well. And I think a special thanks to each one of the participants, each one of the people who's participated for of course everybody participates for winning, but the participation itself, being able to present, being able to share your cases and have that confidence is great. It's a very good platform, and congrats to the entire Naadi team. Yeah.
Thank you, Digvijay sir. Niranjan, next online. Back to you.
We have our vice president, sir, Dr. Karan Bhatia. Karan sir, a few words from you, please.
So, excellent as always. The new NoID team has been doing a great job. A big thanks to Mohan Rajan sir and Sujata ma'am for this wonderful opportunity that is given to the young ophthalmologists of Tamil Nadu, India, and the world. This 3-day event was, featuring with 90 participants from 15 countries, was exhilarating. Privileged and thankful to the panelists and judges for being a part of it. And Naadi and TNOA has been doing great along with YOSI. And big thanks for being a part of it. My sincere gratitude goes to all the office bearers, my esteemed colleagues, executive members, moderators, and the organizers of this wonderful event. And thank you all from the bottom of my heart. And kudos, you're setting the bar higher and higher every single time that you do it. So it's for you guys to, for next year or next time, to make it even better than this. Thanks.
Well done, Karan.
Thank you, Karan sir.
Thank you, sir.
Next, we have our secretary of YOSI, Nilesh sir. A few words from you, please.
Thank you, Niranjan, and thank you, Prasanna sir and Karthikeyan sir, for having me, and Pranesh sir for calling and reminding me that I have to be here on time. It is always a pleasure actually to be a part of this team. Tamil Nadu has been my second home because of me being from my PG from Coimbatore, and me and Prasanna sir going way back from Coimbatore days, and Pranesh sir was also there at that time. It is always a pleasure to work with these guys. Like it never feels like they tell that there is a divide between north and south, and then this is not going north and this is not going south. But I think with this team, it never feels like that. Me learning a little bit of Tamil from them, they're learning a little bit of Hindi from me. And now we are going international, and we are learning all sort of languages because of our international presence. So thank you, great going team Naadi. And Mohan sir, I think you are our celebrity endorsement. Like without without any official sign up, sir praises us so much that it gives us a boost for organizing the next event with even more zest and valor. Thank you so much, sir. Thank you so much for always supporting
Thank you,
us,
Nilesh.
and thank you, the team Naadi, for having me.
Thank you, Nilesh. Brings back nostalgic memories of Coimbatore days. With that, we go back to our treasurer combo, Dr. Avinish sir and Dr. Aditya. The past GC team was very instrumental, and we really wanted to thank Dr. Avinish sir, who was instrumental in when at a nascent stage when we were handling finances Sir guided us on how to go about things. A few words from you, Avanish sir. You have been with us from season 1. Your words.
Think congratulations to you, Dr. Prasanna, and the entire Noinadi team. I think you people have just went a notch up. Like I was a part of season 1 where I was a judge, and cut to season 3 where you are running a 3-day program. That shows how well you're doing it. And at the end of it, I would say that to actually have such a bigger program requires a very good team. And congratulations to your team, the executives of YOSI, the Vice Council of YOSI, I would say. I mean, amazing work, and more power to you people. So, congratulations.
Thank you. Thank you, Avnish sir. Dr. Aditya. Okay. So with that, we move to the country YO leaders. We are joined by Dr. Lala. A few words from you before we move in alphabetical order from Azerbaijan to Mexico. Yeah, you're on mute, Dr. Lala.
Hello, dear all. Greetings from Azerbaijan. Congratulations with a great job. These 3 days, I've tried my best to join to all your presentations. Everything was perfect. You're doing a great job. So proud with that, guys. I can see familiar faces here and many new friends. Congratulations, you're all so proud. And I apologize that I couldn't join today properly because of my OT. And looking forward for more collaborations and corporations together. And good luck.
Thank you. Thank you, Lala. From Sri Lanka, we have Dr. Nirudan. Dr. Nirudan, you are there. Do we have anybody from the Sri Lankan contingent? Okay.
Yeah, Nirutan here.
Yes, Dr. Nirudan.
Hi. Thank you. It was a pleasure presenting myself as well and joining you in this Noinadi 3. And it's very privileged to be a part of it. I can see the dedication and the effort put by the YOSI team and the Noinadi team into this. And we are happy to endure in the future as well with you all. And bring forward much more to the ophthalmology. Thank you.
Thank you, Dr. Nirudan. Moving on to from Sri Lanka to Philippines, Dr. Erika Salvame. Again, another person we are constantly disturbing for the last 1 year, be it International YOSICon 2025 or Noinadi. Dr. Erika, despite she being, I think she was pregnant, but still every time when I call her or I text her, and she was kind enough to send her husband to India despite her newborn. Thank you, Team Pinoy. A few words from you, Dr. Eka, on Noinadi International.
Thank you to our friends from YOSI for inviting us again and opening this wonderful activity to the international community. All I can say is that YOSI is truly inspiring and your mentors are very empowering, and we are all lucky that you are sharing these opportunities to us all across the globe. So it's 11 p.m. right now, but it didn't feel that way as your cases were all interesting. And I congratulate you again from the Philippines. And to our next collaboration, don't worry, I will always answer you and I will not block you. Congratulations.
No, I was just kidding. I know you will not block me. Thank you, Dr. Eka. From Pakistan, do we have Dr. Basha with us, or do we have the presenter? Anybody from Pakistan? The presenting contingent, do we have you guys with us? Okay. From Mongolia, do we have any your leaders from Mongolia to have a few words? Okay. Dr. Mexico, again, a good friend, Dr. Emmanuel. I can see him in the grid. Dr. Emmanuel Franco. Can you hear us, Dr. Emmanuel?
Hello?
Yes, Dr. Emmanuel. We would like to see you as well, all the way from Mexico.
Yes, just a minute. Hey, how are you?
Hi. Yeah, few words on about international YOSI Noinadi season 3. Can we have a few words from you, Dr. Emmanuel? You're on mute.
Yes, of course. Well, it's a pleasure to be here. Thank you, doctor. I mean, I never been in India, but I want. So it's a beautiful country. What a such doctors, ophthalmologists, and everyone. And I'm learning about everything here. So thank you, and hopefully see you soon.
Thank you. Thank you. So with that, from Bangladesh, we saw Dr. Ashraf sir, who has always been a very strong pillar of support, and he always keeps saying Dr. Devakant, Dr. Karan, Dr. Devakant, and Dr. Karan. But I think it's time for us, the next gen of YOSI, to say Dr. Ashraf sir, Dr. Ashraf sir, and his team. So yes, sir. Few words from you, who has always been a pillar for YOSI likewise.
Thank you. Am I audible?
Yes, sir. Loud and clear.
Thank you. Thank you, Prasanna, for having this wonderful conference. It's an online conference, a big event. It's an online international conference. I'm really pleased. And I must thank Dr. Pranesh, who knocked me for and basically who inspired me for joining the Bangladesh YO at this conference. And definitely next time at fourth season, more of the Bangladesh YO will be happy to join this conference. And what Dr. Prasanna said, I would like to thank. I can see Dr. Karan, Dr. Divakant here, Dr. Digvijay here, my old friends, and definitely all the time, Yoshi and BIOS, Bangladesh Young Ophthalmology Society, has a great bonding. And we always learn and share with Yoshi, and definitely it gives also us a good pleasure and good ideas how to move forward. And definitely with you, India and Bangladesh and other South Asian nations, we will move forward with our young ophthalmologists. Thank you very much and congratulations for the successful conference. Thank you.
Thank you, sir. Thank you. It's always a pleasure. For a change, I didn't want to disturb you. So we selected role play and we wanted to make sure we attack you from all sides. Thank you, sir. From Cambodia, do we have any presenting contingent or the YO leaders from Cambodia to say a few words?
Unfortunately, I'm the only one here.
Yes, so we want
But-
you to share your views,
but-
Dr. Han.
Yeah,
It's fortunate for you.
It's very wonderful to be here. This is actually my first time doing a webinar internationally because I only do the at national level, but this is a new experience for me, and I see a lot of case. Then I feel like this is just I have seen only the tips of iceberg. I think I need to learn more and more. This is very inspiring. Thank you very much.
Thank you. Thank you. Thank you, Dr. Han, for being here. And from Egypt, Dr. Pasant, again, another dear friend whom I met at the Taiwan Global YO, not physically, but virtually. I was there physically, but I got to meet her virtually at that time. Dr. Pasant, I can see you among the grids. A few words from you, Dr. Pasant. Are we audible to you, Dr. Pasant? Okay, let's just come back to you and our fellow contingent. Yes,
Hi,
Dr. Yeah. Yes, Dr. Prasanth.
hi, Prasanna and everyone. Well, first, congratulations on this great meeting, on some very great cases. I've learned so much from your residents. The cases were great. The international cases were great. Everything was great. Thank you for this opportunity and for making this, available on YouTube for like future viewing. This is a great initiative. I also want to thank Dr. George Idil for representing us today. His case was great, and I learned a lot. YOSI are basically our friends. They're basically brothers and sisters. Thank you for all the networking that you're doing across the globe. And we will not block you. And we will always be happy to hear from you and to be invited to those great events and webinars. And I also personally want to thank all office bearers and faculty, your judges, The support you're getting in India is just mind-blowing and sets an example for all faculty across the world to support their young ophthalmologists.
Thank you. Thank you. Thank you, dear Prasant, again for being here despite the time zones again. We lost track of time. I don't really know what's the time in Egypt. Thank you once again. So moving from Egypt to Indonesia, again, the dynamic duo from Indonesia, Dr. Vidya and Dr. Alia, two of great friends of YOSI. I could see you guys here in the grid. Are we audible to you?
Hi, yeah.
Yeah.
Hi, Prasanna. First of all, I would like to congratulate all the Naadi and the YOSI family for the great initiative of this webinar during these past 3 days. I know that it's not easy to organize such meeting in this kind of scale. So congratulations. And as always, you guys in YOSI has always been an inspiring example for us YOs across the region and the world. You are so full of energy and so full of initiatives. And I hope that what you are doing right now and in the future will inspire all of us throughout the world, and also to inspire the older generation to keep mentoring and give platforms to the YOs in their region as you guys did in India. So it's such an inspiring initiative. So congratulations for all of you for the successful meeting.
Thank you. Thank you, Dr. Alia, for joining us on such short notice and motivating your residents and fellows for this wonderful event. Moving on to Malaysia. So do we have Dr. Wei, Dr. Vidya, anybody from Malaysia, if you want to share a few words from the Malaysian contingent? I think at short notice, we had multiple representations from Malaysia for this event with more than 3 to 4 representations. Over to the Malaysian contingent.
I would like to thanks Prasanna for always so proactive, organize such a wonderful event, and I'm very happy that our trainee here willing they can present their case. It's a very good platform for them to showcase what is the case that they face in the clinic, and I think it's a very good collaboration between this YOSICON and the very nice international connection between the YO. And thanks again to YOSI for this wonderful meeting. Yeah.
Thank you. Thank you, Wei. It's always such energy to meet you and brings back good Taiwan memories in the global YO. So again, before the last segment is the results, which we are all eager to. I can see close to 73 participants still here despite 841. And I hope we haven't missed any country. Niranjan, so once again, calling out the countries, if we have missed any country. Maldives, Dr. Azam, sir, are you there? I think anybody from Vietnam, anybody from Pakistan, if you guys are here, we would like to hear from you. Nepal, anybody from Nepal, leaders or presenters? I think, yeah, Dr. Nishal.
So namaste to everyone, and I want to thank Young Ophthalmic Society of Nepal, India, for organizing such a wonderful platform for us to come and show our case and gain confidence. So not only this platform gives us the chance to show our cases, it makes us friends more closer to each other, and we are like friends from different countries, but together we are all in the same frame. So this will help us to build friendship also. So very nicely done, and thank you everyone for this opportunity.
Thank you. Thank you.
Hello, I'm from Pakistan. I would like to congratulate the whole UC team. It was a great opportunity, and I'm truly honored to be here and represent my country on such a great platform. Thank you.
Thank you. Thank you, Dr. Shafiq, and thanks to your mentor as well for the excellent participation. And Dr. George, you want to add a few words? Anybody from Cambodia? Did we miss out? Anybody from any other country have we missed out? Before we move to the last segment, Dr. George, are you there?
Yes, sir. I'm there.
Yeah, a quick word from you before we move to the last segment of the day.
Okay. Excuse me. First of all, it's my honor to participate in this prestigious meeting for the Young Ophthalmology Society of India. Really, I was honored for participating. It's my honor. I saw a lot of presentations, a lot of fruitful presentations, which I learned from. So thank you for this great chance, and thank you for letting me present Egypt in this presentation. Thank you so much.
Yeah, and with that, no more delays. I think we have had enough marathon sessions. Results, I would like to call upon Mohan Rajan sir and Sujata ma'am, along with our senior office bearers and past presidents, Dr. Digvijay sir, Niranjan Karthik, Mohan Rajan sir. So we had this 3 capsules, sir. We would like you to announce the results of day 1, which people are eagerly waiting to see which 30 make it up. So we had 95 participants and 30 of them are going to go for presentations in physical international YOSICon 2026. And Devakant sir and Nilesh, the dynamic president secretary duo, along with the governing council, has announced free registration, a complimentary registration for all the residents who are getting selected. Again, Nilesh, a few words from you. I think they would want to hear on that before we take the results to Mohan Rajan sir.
I think so. It was a great suggestion that came from actually Team Noinadi. It was not an original idea from us, but we are more than happy to support each of the presenters who can join us at the international YOSICon that is happening from 19 to 21st June at Delhi. The hotel at most probably at Hotel Pullman, but we are still yet to finalize the location. Ready to welcome everyone at that place. Thank you.
Thank you. Thank you, Nilesh. Mohan Rajan sir, over to you to announce the results of the first session, which was miscellaneous, and these are the top 10 participants, sir. Over to you to make the announcement.
Shall I make the announcement?
Yes, sir, please, sir. It is
Okay.
there and it's up to you, sir. Yes, sir.
Okay, the first prize goes to Dr. Nyanambika M. This top 10 participants in session 1. Am I right?
Yes, sir.
Second one to Dr. Sagila A. Third one, Dr. Neil Kavedia. Fourth, Dr. Apajita Shukla. Fifth, Dr. S. Nishant. Sixth, Dr. V.R. Rahul. Again, I think it's been shared, sixth one.
Yes, sir. Yes.
Dr. Sela Street. And eighth, Dr. Akansha Valdia. Ninth, Dr. Simran Khosla. 10th, Dr. Niba Gupta.
Yes, sir. Sir, and again, calling up to you once again to announce another set before we move to Digvijay, sir.
The session was one was on the day 1, is it?
Yes, sir. This is for day 2, sir. Over to you again, sir, Mohan Rajan, sir, to do the honors for another lot before we leave you, sir.
No problem. Session 2, top 10 participants. Number 1, Dr. Utkarsh Rutki. Number 2, Dr. Annie Anna Abraham. Number 3, Dr. Chandvi Daban. Number 4, Dr. R. Anjana. Number 5, Dr. Arpit Gupta. Number 6, Dr. R. Keetana. Number 7, Dr. Asma Jabin. Number 8, Akansha Valde again. Number 9, K. Janani. Number 10, Kondu Roshita Gagarin.
Thank you, sir. Thank you for taking time, sir, and announcing the winners from the Indian contingent.
What are they? What will be they'll be getting?
Sir, for now, they are all getting the prize of the complimentary registration along with the citation at YOSICon.
Yes.
And they are going to lock ons with each other. We are yet to announce the international category. So the Indians and the international top 40 people are going to lock ons with each other. And we are going to have the top 10 and the top 3 crowned at YOSICon International June 19 to 21 next year, sir.
Okay.
And the award ceremony also will take place then for all of
Fantastic. Fantastic. Congratulations to all the winners.
Yes, sir. Thank you.
All the participants. In my opinion, all the participants are winners.
Yes, sir.
Yes, they are done very well. So all the very best.
Thank you, sir. Thank you, Mohan Rajan, sir, for taking time. With that, we'll move from one vice president to another past president of YOSI, Dr. Digvijay, sir, to announce lot number 3 for anterior segment top 10 participants. Over to Dr. Digvijay, sir.
Thank you, Prasanna, and congratulations to all the winners. The first is Dr. Rohini H. The second is Dr. Bahubali. So third is Dr. Sneha M. Fourth is Dr. Vidushi Dikshit. Fifth is Dr. Swetarshi R. And sixth is Dr. Suvarna Chaji Tugli. Seventh is also Dr. Suvarna. So that's two times together, is it?
Yes, sir. Two
And
cases. She had
two
two different.
cases. Okay, okay. Eighth is Dr. Jayapriya P. Ninth is Dr. Nishan. And 10th is Dr. Sacharna Anbalagan. So congratulations to all the winners and to all the participants, in fact. And of course, it's a fantastic event we've had.
Thank you. Thank you, Digvijay sir. With that, we are going to move to the international contingent categories. And none other than Sonal ma'am, who sowed the seeds for Naadi in season 1. Ma'am, we have two different categories. One will be done by you and the other one will be Devakant sir. So first we'll have the top 10 international participants by Sonal Kalia ma'am. Over to you, ma'am.
Thank you so much, Prasanna, for your hard work. You've been praising so many people, but I want to, really begin by praising you. So I would request all of you to please raise virtual claps for Prasanna for his hard work, not just overall as Joint Secretary YOSI, but for this event particularly. He has worked hard through all 3 seasons, and I remember with so many confusions that we had in the first season, we used to sit and discuss things on long calls, and now also the long calls continue for different reasons, although. And so, congratulations to all the national participants and now the international ones as well. The first one being from Sri Lanka, Dr. K. Nirutnan. Followed by from Malaysia, Dr. Ariana Binti Syamsdi. Please really pardon my voice, which is cracking up. I'm unwell. And from Mexico, the third winner is Dr. Emmanuel Franco Gomez. Fourth is Dr. Rizka Yunanda from Indonesia. From Mongolia, there is Dr. Delgezrul Bat. Again, this is really cheating, given the most difficult names to me. From Nepal, there is Dr. Nishil Ghimre. Then from Malaysia, there is Dr. Mohammad Fadil bin Abdul Zaim. From Malaysia, Dr. Nurul Afzan binti Mustafa. From Philippines, Dr. Jed Mikhail T. Tabangura. And from Azerbaijan, the 10th one, Dr. Gunel. I really apologize to all of you if I've mispronounced any of your names. I'm not familiar with them. But I hope with the spellings written correctly over here, you would all know who you are. Congratulations to all of you. And over for the next set of prizes to Devakant.
Yeah, I would like to call upon Devakant sir again, the
Yes,
man
Prasanna.
who we all follow. 5 years back, late back when we saw you, sir, in the International Heroes section, connecting with all Vayos internationally, that was an inspiration, at least personally for me. And we all took you up very seriously. You are the person who always say, Yos have to shift and move international. And your vision, this YOSICON at IYOC, the International Vayo Council. I think for all our international colleagues out here, Dr. Devakant sir's brainchild is the IYOC Council to bring all colleagues across globe. And I think we are just extending the seeds that you have sowed. And I think YOSI is going international under your wings and your leadership and guidance. It will be apt. You announce the last set of the day, which is again another international category from each country. Over to President Dr. Devakant sir.
Thank you so much, Prasanna. So this is the best performer from each country, right?
Yes, sir.
It's Dr. K. Niruthan from Sri Lanka. Again, Dr. Ariana Binti from Malaysia. Dr. Gomez from Mexico. Dr. Yunanda from Indonesia. Dr. Bhatt from Mongolia. Dr. Nishal from Nepal. Dr. Zed Mikhail from Philippines, Dr. Gunel from Azerbaijan, Dr. Saima from Bangladesh, Dr. George from Egypt, Dr. Hun from Cambodia, and Dr. Shafiq Tanveer from Pakistan. So congratulations to each of these countries who have, connected with us on this platform. And it has been very inspiring for I feel the Indian young ophthalmologists and both the international ones to connect on this platform that our team has created. So again, thank you, Team Naadi, for doing this. and we are already looking forward to the finale in YOSICon and the next Noinadi as well. Thank you, Prasanna and team.
Thank you, sir. Handing it over back to Karthikeyan regarding what's up next. Before we end up with a group photo, Dr. Karthikeyan, the man who coined the term Noinadi, a few words on the trio that I will be failing in my duty. Karthikeyan has really worked day and night for this particular season. And he's the guy who always initiates it and starts pushing us to the cane. And he stays in the background, and Noinadi is his baby. It's his vision. And we three have now come together, and now we don't even know who the leader of this clan is. And we work in such a way that each one of us takes one step forward. Be it Dr. Niranjan, who's the guy behind all the Excel sheets, all the data cleaning that after the Excel takes place. Niranjan is the guy. And he's the guy who contacts everybody after getting the contacts from each one of us, who does all the back-end tireless job. To Niranjan, Karthik, a huge shout out. Again, Karthik and Mahalingam for physically pushing submissions from all around. And Dr. Pranesh Ravi, another pillar, I should say, for all the tremendous phone calls and to get the results compiled, verified, the statistical analysis that this competition needed. I think we would have been unprepared if not for Pranesh, because we had 95 and all the statistical analysis had to be done. And he was the statistician behind this to make sure not even a single result will not go wrong. And he made sure the validation was perfect and the results were announced in a very fair manner. Over to you three to share what's up next in pipeline. As you can see, how do they go from here? The next 50 winners of this day.
Thank you, Dr. Prasanna. As said earlier, 2 years back, under the leadership of Sonal ma'am with madam's support, we planned and we started this Noinadi event. Initially, we started only for, we had a vision along with Dr. Pranesh, Dr. Niranjan and Dr. Prasanna. All we had a vision that all the postgraduates should present their case and gain confidence. They usually don't present. So we started with only with Tamil Nadu YOS in the first season. It was a huge success. Around 30 plus submissions came. And we took the way forward to 2025 next year in the season 2. We started including all the Indian news. Why not? We'll include all the Indian news. Then we did the same as Prasanna said earlier. Prasanna was behind all these posters in the first 2 seasons. And Niranjan, all the phone calls. Pranesh, all the technical support, scores and evaluation. And in season 2 and season 3, Devakant sir and Nilesh sir gave us full freedom to do whatever we want. And suddenly Prasanna asked, Karthik, initially you had only for Tamil Nadu news. Second season you had for Indian news. Why not we take to international news? He said, international news? I don't know anyone. Is it possible even the international news coming and participating in this conference? How will they know about it? I said, Prasanna said, if you want, I can make it. Yes, it is. Because of him, 15 countries participated. Otherwise, this international event won't happen. So all credits goes to Prasanna for making it international. And all the 4 pillars like Prasanna, Pranesh and Niranjan, everyone worked very hard day and night to make this possible. And every time you were calling and disturbing, initially in first season we called Sonal ma'am and disturb. Then second and third season we called Devakant sir and Dr. Nilesh sir. Again calling and disturbing, we are going to make this, that. We are doing this. We had 2 more support apart from Prasanna, Pranesh and Niranjan. We had Dr. Aditya and Dr. Samir, who supported this in the 3rd season. And we have to thank all the judges in the prelims of all the seasons, season 1, season 2 and season 3 was particularly hectic. We had more than 30 cases in each session. They patiently sat through, and all the judges and panel who were helping us. So I thank everyone, and I thank all YOSI past president, past GC and present GC and TNOA President Sujata ma'am and Vice President Mohan Rajan sir, who came for this valedictory ceremony. Thank you so much.
Handing it back to Niranjan and Pranesh, who are again the dark horses. Few words from you guys before we conclude it with a group photograph.
Sir, I wouldn't take much time, but greatly indebted and blessed to be a part of this initiative and to be working with uh, all three of you and under the leadership of our YOSI Governing Council and the blessings of our seniors from both TNOA and AOS, sir. Thank you. Thank you so much.
Pranesh.
Thank you, Prasanna, for pulling the lot of effort and pulling all international people for this Noinadi. Thank you to all the President Mohan Rajan, Sujata ma'am, the governing council members, the past presidents of YOSI. We have worked really hard. We have even today morning also we have been crunching the numbers and scores. And thanks for the support from our fellow colleagues. Even in one person absence, we are able to cover up the other, and I'm really happy that Touchwood this continues for years together. Thank you very much.
Yeah, so that brings us every good things comes to a close, and we are striking 9. And we would also like to thank Team Numerotech. Team Numerotech has been a real pillar with that stopwatches, 4-minute timer. I think Sai sir and Manjula ma'am and Team Numerotech, if you guys are here, we would really like to acknowledge you. Not a single blemish was there, and we started on time and we ended on time. And each and every people, our executives are there. We would like you guys to say a few words. Ayushi is here, Lipi is here, Arshi is here. Each one took different roles. When we approached them, some people told we'll take judging. Some people told we'll go for panel. Lipi told I'll go for panel. And we wanted a moderator, Rolika came in. So we wanted a judge, Arshi Singh came in. I can see them still attending here. If you guys have anything to say, because without you guys, again, I think it's not possible for us to pull off these kind of magnum opus events. So I think we are nobody without our team, YOSI. And if you guys can say something, any participants, if you want to say something, you guys are feel free to say, and we'll close it with a photograph.
Thank you, sir. I just want to congratulate the organizers for the months and years of hard work to pull this 3-day international program off. And we don't have many exclusively resident initiatives per se globally as well. But this is one of the best ones that I've come across till now. And another thing that I would like to say is that at LVPI, we used to have this motto, so that all may see. And I think this is a platform where, so that all may learn from each other. So congratulations to all of you. And thank you for having me.
Thank you, sir. I would like to thank Prasanna sir for including me in Naadi, and I would like to congratulate the whole team for their hard work. I mean, it is very difficult to coordinate with so many people in just one country, and you guys have done an outstanding job in coordinating with so many different countries. And it was a very, I think, good platform for all the residents also to participate and present their cases. Looking forward to more sessions. Thank you, sir.
Same, I would just like to echo everything that just Ayushi has right now said, and Lippy also said. The team has done great work, and thank you so much for a very enjoyable 3 days. I have been following everything on YouTube since last year with Naadi, and now that I know what it means, Dr. Karthikeyan, it has a wonderful meaning, especially the shloka that you shared. And I would specifically want to extend my thanks to all the participants from international waters and from India, because you all shared all your cases, even the tough ones, the ones who were difficult to manage. It is because of you all that we could learn so much. And now anyone who goes back and listens or watches these videos will have a lot of power packed learning knowledge consolidated in these 3 sessions that they'll see. Thank you so much for having me.
So without much delay, requesting all to switch on the camera. I think all good things come to a close, and here we are for a mandatory YOSI group photograph. Yes, requesting all. Pranesh, you also start taking. I'll also start take. Let's see how many grids we can cover. It's very heartwarming to see 2 grids fully full despite the time zones. 3, 2, 1. Cheers. Right.